现在可以参加 Zoom 吗？Hello，阿信，喂，你好啊，唔好意思，你而家裝唔裝到啊？
裝到，
哦，OK，係1分鐘開始，Thank you，拜拜。Hi, good afternoon, everyone. Actually, good evening, everyone. Welcome all of you to the competition on this dialysis access. It's the first, this is probably the first preliminary event that we have for Asian Society of Vascular Surgery meeting in 2025. And also this competition is actually on a theme of best salvage for the worst complications. So before we start, I really want to thank from me and also all the judges and organizing committee for all the contestants for submitting your case and participating in this competition. Of course, in the competition, we have to give scores, and finally, we select 5 who will present the case again in the actual meeting on 29th of August. Nevertheless, every single one of you, your cases are valuable, and it's a great opportunity for all of us to learn and discuss. Yeah, so I would like to also introduce now the judges of today. Dr. Yong An Ming is from Singapore Tan Tock Seng Hospital, vascular surgeon. And then Dr. Billy Karundin is from Indonesia, also vascular surgeon. Yes, thank you. And then Dr. Chen is also from Hong Kong. He's also a vascular surgeon. Yeah. Okay, so I think all of you already have the information that we will be scoring according to the contents. How do you explain the severity of the complication and the challenges, and also your solution, durability and practicability, and also any innovative component, and also on the overall global presentation skill and all the audiovisual presentation. So it will be a 6 minutes presentation. You will hear a bell to inform you about the time to round up your presentation, and then we will have 4 minutes of discussion. Yeah, so all the judges, please feel free to send your questions, and I think discussion is as important as the presentation as well. And then between each of the presentation and after the Q&A, we will have like a 1 minute break for the judges to fill in the form and submit the score to the to our organizer. Yeah. So I think yes. Okay. So without further ado, I think we will kickstart this competition. And I would like to invite the first contestant of this evening, Dr. Bernadette Lee from Australia. Dr. Lee, thank you.
Hello, can you hear me?
Yes, yes, we can hear you, and you can share your presentation.
Can you see that now?
Yes.
Fantastic. Okay, so without delay, I will go kickstart into this presentation. We are presenting on a salvage AVF in a patient with serious upper limb peripheral artery disease with central venous stenosis in a young man with limited vascular options and minimal options for venous lines. This is Mr. PG. He is a 41-year-old man. He's left-hand dominant. He is an end-stage renal failure patient secondary to diabetic nephropathy. He has a complex vasculopathy background. He's had a previous type B aortic dissection requiring a TEVAR. He's got ischemic heart disease, peripheral artery disease in his upper limb and lower limb, has central venous stenosis from complicated previous central lines that we've had to intervene multiple times. He is a man who is persistently hypotensive despite best medical therapy. He had presented to us with a right brachial cephalic AVF that was created previously. This was done externally, and when the patient came through, this was done in Australia interstate, so not within our state. We undertook multiple attempts at fasciculoplasty and stenting in 2020, and we attempted to try and reopen the stent for multiple stenosis. Unfortunately, the AVF thrombosed in December 2020, and it was deemed not salvageable. A left brachiocephalic AVS was created soon after. Unfortunately, this was complicated by Steele syndrome with upper limb ischemia and severe pain. There was multiple attempts to salvage, including even a Rudy procedure. Unfortunately, the pain became too critical for the patient, and the decision was made to ligate his AVF. This was the end of 2022. So in summary, we had a young patient with no ideal conduit. He had central venous stenosis. He was very hypotensive. We were running out of options in terms of what we could do in terms of hemodialysis. We took multiple multidisciplinary meetings between renal medicine, vascular surgery, and interventional radiology. We attempted to do multiple diagnostic angiograms and venograms in his right arm. We were trying to seek out a more distal size cephalic vein as well as artery, knowing very well that he had a diseased radial artery which was occluded. So in summary, if we tried to do anything in terms of a more distal conduit in his forearm, he was at a very high risk of Steele syndrome. A quick review of his CT venogram showed a good vein size in his forearm. Angiogram that was done showed a single arterial supply to his hand via his ulnar artery, which interestingly also then showed a back retrograde filling of the radial artery. As we know, the requirements for AVF creations are listed down below, and the patient's measurements were not in line with the current requirements. Preoperatively, we considered and made a few decisions. As mentioned, he's a young patient, has non-ideal arterial supply and previously created AVF that was in the proximal arm. He had minimal options for further AVF in his upper limbs, and use of central venous catheters were just difficult for him in someone with central venous stenosis and also with any subsequent risk of line infection. Weighing out the risk and benefit for this patient, we considered that given it was a fairly low risk procedure, we should try to consider making a right radiocephalic AVF by first recanalizing his radial artery. This will obviously require very close surveillance of AVF post-creation. This is where we are in terms of his angioplasty. I'll show you a picture of us intraoperatively. Intraoperatively, just looking at the pictures, he had a brachial artery excess. We stenosed and crossed the stenosis with a 014 wire, and we pulled out the radial artery with good result. We then did an end-to-side arterial anastomosis with a long hood and slightly offset with a loop orientation in order to prevent further neointimal hyperplasia. Angiogram showed persistent stenosis in the radial artery after we made the AVF, so we made a decision to pull out the entire fistular swing segment and radial artery. So this is what it looked like. You can see down below the ulnar artery continues to be inflow. There's a flow through his radial artery into his AVF, but it was quite stenotic. We then decided that we would continue to do a angioplasty into his radial artery, extend it further into the swing segment and across the entire AVF. There's been no change in terms of the flow into the ulnar artery, and the next picture will review that he had good flow into his hand. So following everything that the patient has been through, it's been 20 months now, and towards the end of this year, he'll be closer to 24 months. In a patient who had who had minimal arterial supply and venous supply, and who was persistently hypotensive despite our treatments, we managed to distally create a radiocephalic fistula. It required a few very close surveillance. We've had to do further angioplasties for his stenosis. Certainly in the arterial stenosis, that has continued to be an issue for him. But with close monitoring, we've managed to keep it open. He's had a stent placed in the swing segment to ensure patency. But despite all that despite all of his past medical history, he has no further need for central venous lines, and he's able to continue to dialyze through the AVF that he currently has. And that is the end of my presentation.
Thank you, Dr. Lee, for sharing with us this very challenging young patient with long history of dialysis. Any question from the judges? I think we have 3 minutes of Q&A.
Can I ask Dr. Lee, what are the other alternatives if we didn't do this procedure?
Perhaps the patient would need to be considered for a continuation of hemodialysis through other central lines. He may, depending on his abilities to manage, he may be considered for peritoneal dialysis. But once again, that exposes him to further infection risk, further risk of other conditions that would come with a peritoneal dialysis catheter. I think that in a young patient, the options for hemodialysis would always be preferred. Additionally, he would have had to manage all of his catheter managements at home, which would not have been ideal for someone like him with, I guess, not very much family support.
Thank you.
Any other question? Dr. Lee, can I also ask, like, the highly stenosed or occluded radial artery, what kind of evaluation that will you really, after the assessment, what are the features that you think that this patient highly likely intervention will be successful? Or you think no matter how difficult or all the circumstances, one should at least give it a try.
I would agree. I certainly think that regardless of the circumstances, it was a low risk procedure for a patient who, I guess, it could have had no options for dialysis. I think that given the circumstances, if we were able to cross the occlusion as we did, and we were able to recanalize it and reopen it, a radial flow into the fistula would have been worth trying, and certainly would have been worth attempting for someone who has had no further options for
How
creating
about a bypass graft from the
yes,
brachial
from
artery?
the sorry, I missed that question. A bypass from the brachial?
Yes,
So brachial into radial or brachial into ulnar?
the fistula. Just to
Brachial into
replace the whole radial artery.
So brachial into direct into the fistula?
Yeah.
I guess he would need a conduit for us to be able to do that. And he had potentially not a great conduit. He had a good cephalic vein, but the lengthwise and to be able to create a conduit, we were not certain that we were able to create one.
Okay.
Perhaps it was a decision that could be discussed further, but I think in the
Thank you
event
very
that
much,
we were not
Dr.
able
Lee.
to
Time is up.
open it.
Thank you very much. Yeah, and thank you. Really appreciate you bringing this very challenging and interesting case. And I think it's always good to know these kind of challenging conditions, what options people can actually get to maintain the dialysis access of patient. Yeah, thank you very much. And then following Dr. Lee, I would like to invite Dr. Fan Zhang to present his case. Dr. Zhang.
Okay, hello everyone. Let me share my slides. Shall I start?
Yes, please.
Okay. Good evening, distinguished judges and colleagues. I'm Fan Zhang from the Department of Nephrology, Beijing Haidian Hospital, Beijing, China. And it's a great honor for me to participate in this competition. And today I will present a challenging case of direct puncture treatment for the cephalic arch stenosis and severe cephalic vein tortuosity, followed by extravascular bypass stenting. Our patient was a 46-year-old male admitted to a hospital on May 22nd, 2023, with 20 years fatigue and elevated venous pressure during dialysis, accompanied by difficult hemostasis. And he started regular hemodialysis on 2016 with successive vascular access via the right internal jugular catheter, left radiocephalic AVF, right umbilical AVF, and then it's a left brachial cephalic AVF. So on examination, the blood pressure was 139 over 90 millimeter mercury. The patient appeared chronically ill. The thrill at the left upper extremity AVF site was diminished with the increased possibility. A palpable thrill was also noted over the left shoulder region. So based on the clinical evaluation, we diagnosed the dysfunctional AVF with suspected cephalic arch stenosis. After admission, the angiography confirmed the stenosis. Also, it revealed another critical finding, the severe tortuosity of the cephalic vein. So this is a durable challenge. How to concurrently address the cephalic arch stenosis and the cephalic vein tortuosity. So current option for the cephalic arch stenosis include PTA, stents, or open surgery. And the stents should the priority on 12 months primary patency. And for cephalic vein tortuosity, open surgery or the endovascular stents could be employed. So what's the possible consequence if the cephalic vein tortuosity was left unaddressed? This may lead to the difficulty in guide wear catheter advancements or stent deployment. Also, it may increase the re-intervention complexity for the future restenosis. So for this patient, we proposed a comprehensive treatment approach, try to address both issues simultaneously. So we use the direct puncture treatment with axial vascular bypass stent. Let's have a look at the case steps. So step 1, the direct puncture. The puncture needle sequentially traverses the skin, subcutaneous tissue, intravascular lumen, extravascular space, and then re-enter the vascular compartment. And step 2, a guide wire was then introduced to the needle and then advanced into the catheter shells using a loop technique. And step 3, finally, a Cavaro stents with diameter of 10 millimeters were finally successfully implanted. It should be paid attention to that here. The maximum diameter for Cavaro stent is 10 millimeter, and the vessel for the vessel size diameter is 11. So relative to the venous diameter, the Cavaro stents was underside placed. So this comprehensive treatment addressed the stenosis and at the same time straightened the total vein, reduced the future procedural difficulties. 1 month later, on the ultrasound follow-up, we found there is a distal compression and also instant thrombosis. So what's the possible causes for the stent compression? So as the video shows here, previously, we have observed a similar situation in other patients. So during the excessive shoulder flexion, the stent kicks, which increases the vascular pressure, especially in the upstream of the stent. Then the underside Cavaro stent collapse from that pressure. So for this, to resolve this problem, we use the open surgery to anchor the stent to the vessel wall with proning sutures to prevent the future hemodynamic compression caused by the axial forces or the patient's motion. And 1 month later after the operation, the angiography confirmed the stent edges remains in good position, and both proximal and distal stents are well aligned, no signs of stent compression or no recovery of the thrombosis. AVF remains patent and functioning normal. So this case suggests that extravascular bypass stents could straighten the tutus vein, and for the Cavaro stent placed in an underside manner, it should be paid attention to the possible risk for the stent compression. And this is all my presentation today. Thank you for your attention. I welcome any questions.
Thank you very much, Dr. Zhang. I think this is really a very interesting and challenging condition. May I ask all the judges, and before that, I have to beg your pardon because just now I forgotten to introduce another judges of today, Professor Fu Qining from China. He's a vascular surgeon, very experienced in dialysis access. Yeah. Okay.
Never mind. Thanks for invitations to be a judge of this interesting competitions. For this case, I just have one question. First, I have to say, the treatment is really very imaginative. Really, it's very yes, it's very interesting, and in fact, you bring two different situations here. First is twisted cephalic arch stenosis, and the second is the compression of the stent.
Yes.
Yeah, the two ways you treat these things is really very good. My question is, when you make decision between put the stem there or do open surgeries, since the twisted parts, I think it's long enough to do open surgery. So how to compare the to your opinion, so what's the benefits of the ways to use stems instead of open surgeries for this case?
Oh, okay. Thank you, Dr. Fu. Thank you for your question. So actually, this imaginative surgery was done by Dr. Shen Zhang. And yeah, thank you for your question. Your question is how to make a decision between the open surgery and the stent implanted. Yes. So for this for these patients and in our century, so our experience for this kind of stenosis and usually we would like to prefer to choose the endovascular treatment. That's to implant a stent, cause it's a minimal invasive way to address the stenosis. And for this patient, yes, there is it's a severe tortoise for the cephalic vein. So we try to find a way. We use this bypass, extravascular bypass stent to address these two issues simultaneously. So and during the follow-up, we found that the patency issued a very good long time patency. Yeah, that's why we choose this method.
Okay, thank you.
Thank you.
Thank you, Dr. Zhang. Any other question?
Yes. Thank you for your sharing. My question is, when you do the stitch for the stents, in which location you perform the stitch, and how many location? Just one place in the edge of the stent, or how many? Thank you.
Thank you for your question. So sorry, you mean which location is the
Yeah, in which
stenosis?
location of the stent, in the edge of the stent?
So the lesion of the stenosis is just very close to the configuration of the cephalic arc to the axovenous vein. It's just near this part, and I can show you the stents after the implements. So the Carrera stent is the size, the length is 10 centimeter. It's around in this area, just around in this area. And just the one Carrera stent here. Thank you.
Okay, thank you.
Dr. Zhang, can I ask the choice of Covera stent where I noticed that you mentioned the size of the vein is, or the fistula is actually about 11 mm. Would you consider other cover stent that have a larger diameter?
Oh, yes. This is what we think about before. Thank you for your question. So for the stents, besides Cavaro, we can also use Verbum, which both of these two kinds of stents showed the higher patency when compared with the bare stents. And but for the Verbum stents, the COF, I think it's relatively larger than the Cavaro stents. So for this kind of situation, and for the cephalic stenosis here, if we choose Verbum, maybe there is a higher percentage of the restenosis. Yeah, so that's why we should you should cover a stent. Thank you.
Okay, thank you.
Mm-hmm.
Thank you very much, Dr. Zhang. So we will have a 30-second break to have the judges to fill in the score form first, and then we'll come back very soon. Okay, thank you very much. And then we will have Dr. Samuel Low from Hong Kong to present his case. Dr. Low, please.
Hello, can you hear me?
Yes. Yeah, we can hear you and see your slides.
Thank you. Good evening. My name is Dr. Samuel Low from the Pamela Universal Eastern Hospital in Hong Kong. And today I would like to present a case of thrombosed AV graft to you with complication after endovascular thrombectomy and salvage. The patient is a 49-year-old gentleman with end-stage renal failure on hemodialysis via left forearm loop AV graft since 2022. And he presented with AV graft thrombosis with loss of thrill and unable to dialyze. We planned for an endovascular thrombectomy with a rheolytic thrombectomy device and utilizing a bidirectional sheath strategy. So I inserted the sheath at the A site and crossed the thrombosed graft with a soft terumo J wire and a burn catheter. The closest outflow is the cephalic vein, so I attempted to pass the wire further to the cephalic vein, but it resulted in extravasation. So I decided to double back through the antecubital into the basilic vein. And I was able to cross into the basilic vein. But you can already see that the angle between the antecubital vein and the basilic vein is very acute. But after passing the wire and after passing the catheter, now the angle has softened and become more of an S shape, and we exchanged to a stiff wire. And this S shape will be more relevant in the subsequent complication. Afterwards, we have inserted the thrombectomy device over the stiff wire. Passed the vein graft anastomosis, passed the VG anastomosis, and inject some contrast, and then it confirmed the outflow patency. So proceed to start the thrombectomy by pulling back the catheter back, but there was severe resistance, and I couldn't do anything. And you notice after the two dots of the catheter have separated, the catheter tip has avulsed. And so at first, I tried to pass a body wire with the intention to snare the catheter, but it didn't work. So I can't keep the wire. I have to break the wire. And there's an interesting phenomenon. The J tip of the stiff wire helped to pull back the catheter fragment closer to the sheath, and subsequently use a snare to take the catheter fragment out. And so back to square one, then start again, pass the soft wire back into the basilic vein, and this time manage it with some balloon maceration of the clot, making sure the balloon doesn't go past the VG anastomosis, inserting a retrograde sheath to the V site, the further balloon maceration and aspiration of the clots. And final fistula confirmed the patent circuit. So to summarize, this was a procedure complicated with thrombectomy catheter tip ablution and managed with retrieval with snare under fluoroscopy. The AV graft thrombosis was managed by balloon maceration technique, and the final outcome was that the graft was patent and the patient was able to dialyze post-op. But the most important question today is, why did it break in the first place? Our first instinct may be to blame the product, but we encounter many kinds of loops and curves during surgery. For example, tortuous iliac arteries when performing EVA. And these can be usually managed by straightening them out with stiff wires. Or sometimes in the sigmoid colon, we may encounter alpha or beta loops when performing colonoscopy. And we may perform reduction with colonoscopy, again, to straighten out these bends. What's the difference with our patient? Here's a picture of the tortuous S-shaped bend. Please excuse my poor freehand drawing. In number 2, the catheter is pulled back. This partially reduces the curve, but also narrows the vein. And the catheter is caught in this tight vein, in this artificial stenosis, and can't be released. Excessive force causes the catheter to be avulsed. And this is an effect similar to that caused by the Chinese finger trap. Let me elaborate. This is actually, the Chinese finger trap is a toy, actually. Sometimes you as party favors in children's parties. As you put your fingers inside, as you insert your fingers in both sides, as you try to pull the fingers out, it narrows and your fingers are trapped together. The solution is your fingers together again in order to be released. It's a little bit similar to the superior stent. If it is packed tightly together, the diameter is wider, and if it's elongated, the lumen is compromised. So the management strategies include prevention by awareness and identification of these of this situation very and careful of these S-shaped bands now to avoid being trapped. And another way is using a short wire strategy. Usually we will keep a long wire far into the basilic vein, but instead, in order to prevent the trap, then we may avoid the wire crossing too far into the S, and or even by any alternative route. For example, if I kept the wire in the cephalic vein, then this would avoid the trap altogether. And lastly, there is a through and through wire a strategy where we insert a sheath, a retrograde sheath, beyond the S shape and keep the wire loose and not under tension. And this could have been a possible solution if the catheter tip was not visible under fluoroscopy. So, ladies and gentlemen, this was a patient with a thrombosed loop forearm AV graft with a tortuous S-shaped outflow vein. And the tortuosity resulted in the thrombectomy catheter tip being trapped and avulsed, causing the Chinese finger trap phenomenon. And the management of this can be either through prevention, to utilize a short wire technique, or utilizing a loose through and through wire. So thank you very much.
Thank you, Dr. Low, for bringing in this interesting and challenging case, and also a very nice resolution of the problem at the end. May I ask any questions from the judges for Dr. Low?
Hi, Dr. Low, Ming here. Just one comment, I guess. When you initially when you're presenting, when you said Chinese finger trap, I thought you were going to be describing using your hand to dislodge the catheter from the outside. Just one question. How long did you take to retrieve the catheter? And when you were actually passing the thrombectomy device up, forward and also back, was there any resistance? Just to also find out how this complication could have occurred.
Yes. When I passed the thrombectomy catheter in forward, then there was already some resistance, but it was still possible, nothing too serious. But then as I passed that curve, past that VG anastomosis site, and then tried to pull back, then the catheter got stuck at that site. And I hadn't even started the thrombectomy then, and it already got stuck there. Subsequently, because the catheter tip was very close to the sheath, then actually that facilitated the snare retrieval. So that was too difficult. A more challenging situation would have been if the catheter tip was radiolucent and not able to be seen under fluoroscopy. In case, then it would definitely not be a good idea to take out the wire, but then we would maybe use a different method.
Thank you. Very nicely done.
Actually, Dr. Low, I miss out the reason, but I just wonder, seeing your angiogram, there is also an outflow into the basilic vein, or is it a brachial vein? I just wonder.
Yes.
Yeah, I just wonder why not trying to use catheter or other maneuver to park the wire over the basilic side. Yeah.
Hello. Hi.
Yes.
So sorry.
Yeah, back.
Yes, you might be right. I can't because this case was a few years ago, and we didn't need a retrograde sheath in the end. So I actually forgot if it is the brachial vein. You're probably right.
Okay. Right. Professor Fu, any question?
I just have the same question as you just mentioned. Maybe you can. Why you didn't use another access to create another access to go to the Braylic phase? maybe that's will not that long, and it can more easier to go past the basic way. And have you do ultrasound to assessments basic way before your procedures?
Yeah, because usually when I perform the thrombectomy, then I might utilize this double sheath technique where I puncture the A site or the V site, and I would like to preserve the upper limb veins for future access creation and to avoid puncture if possible. But definitely, the basilic vein, is probably still available to be used as an access site, if any complication arise.
Okay, thank you very much, Dr. Low. We'll have a 30-second break for the judges, and I will come back very soon. All right. So following this, I would like to invite Dr. Muhammad Asid Ismail to present his case. Dr. Ismail, thank you.
I can start my presentation. Can anyone check is my voice clear?
Yes, we can see the presentation.
Okay, good evening to all. My name is Isaac. I'm from Malaysia, and I'm a vascular trainee.
Your voice might need to up a little bit.
So, okay, sorry. I'll try my best to speak
Now it's
louder,
better.
if it's okay. Okay,
Yeah, thank you.
right. Good evening to all. My name is Isaac. Thank you for accepting this case for this competition. It's an honor to be part of this section on ASVS. I'm going to share with you our case experience in our center for best salvage for the worst complication, salvaging the unsalvageable, and how we managed to revive a recurrent thrombus BCF through endovascular approach. So this will be the content of my presentation. As we all know that AVF thrombosis is a serious complication. It represents the end stage of a progressively failing vascular access, which can lead to permanent access loss. Studies have shown that early thrombectomy is associated with improved patency and also reduced access loss, while previous guidelines recommend open surgical thrombectomy, but recently endovascular technique has become the preferred approach as it offers a lower mobility and effective restoration of the access. So this is a case of 45-year-old lady with ASRF using on the regular hemodialysis using a right BCF for the past 7 years. The patient first presented to us with a thrombus fistula on April 2025. She was unable to dialyze for the past 2 days, and she was not seen for the IJC catheter insertion. Our duplex revealed a thrombus AVF, as you can see from the anastomotic area at the segment A up to the V. She is a foreigner who works in a maid agency, so there is a significant financial constraint. We decided to perform endovascular technique. We decided to use our own budget for this patient. So we initially performed through retrograde access by 6 French sheath insertion. However, we couldn't pass through the lesion at the proximal aneurysm area. So we inserted another anti-grade access, and through the anti-grade access, we were able to pass through the lesion, and histogram showed that there is a significant obstruction of thrombus, and from the central venogram showed a patent outflow and also a patent central area. Subsequently, we performed a percutaneous thrombolysis by injecting a urokinase into the thrombus under 80,000 units, followed by a blood balloon maceration using a 6 mm and 8 mm balloon. Post-plasty, the balloon was well effaced distally. However, we noted there is a minimal recoil at the proximal area marked as A. However, in view of palpable thrill and breeze flow, we completed procedure. Patient was able to use the fistula subsequently. Upon a month follow-up, patient was able to use the fistula for dialysis. We noted that the patient still has a stenosis and we counseled her for further intervention. However, she refuses as she was unable to take leave, and there was also again a financial problem. So we decided to discuss this further treatment with the employer on the next appointment. Unfortunately, the patient came back earlier. She presented with again a thrombus fistula. Ultrasound showed complete thrombosis of the fistula from the same area at the anastomosis up to the proximal arm. So again, at that point of time, we managed to counsel the patient, also the employer. So the employer managed to cover the patient financially. So when we performed the subsequent fistulogram, we inserted retrogradely. We were able to pass through the lesion, and the histogram showed there is a complete obstruction. Actually, there is no flow into the fistula. And subsequently, we injected a thrombolysis epiclase directly into the thrombus to break the blood and also the thrombus. Following that, we pre-dilate with a POBA balloon 5 mm at the anastomosis size, 6 mm at the swing segment with wasting at nominal pressure and a well effaced at rated pressure. Subsequent fistulogram showed a residual thrombus and a recoil at the plastic segment. So we decided to add 6 mm cutting balloon throughout the full length of the fistula, followed by 8 mm balloon maceration. We also added external manual massage to macerate the thrombus. Completion fistulogram showed a very good flow with palpable thrill. Patient was able to use the fistula. This is the post-procedure ultrasound. We showed clear of thrombus. 1 month surveillance confirmed that the patency is patent. So when we talk about AVF thrombosis, the decision to perform either open or endovascular depends on the expertise of the sample. The key guideline latest recommend that endovascular therapy as a first line, as it has a high technical success rate with a primary patency of 3 months, 50 to 65%, 6 months, 40 to 50%, and a year of 50 to 40%. Why we choose percutaneous? Because one of the principle is
because now you are 1 minute over time already. Would you like to go to the Q&A section?
Yeah, sure. Yeah.
Okay, thank you very much. So
Right.
any question for Dr. Ismail? Professor Fu?
Yes. First, thanks for your wonderful case, and congratulations that you successfully treat the surfaces with endovascular ways. Since we know for patients with aneurysms and surfaces, sometimes the surfaces could be chronic, so it's not easily to treat with totally endovascular ways. So, how will you make decision to totally use endovascular ways to treat these surfaces, or use open surgery to get these clots out?
Okay, of course, first I will look at the patient as a whole. If the patient is willing to undergo a catheter placement first, then there is an option for open. However, now that the guidelines is recommending endovascular approach first, so if the patient in ideal setting, I would offer patient endovascular approach with a pharmacomechanical thrombectomy device. It depends on the thrombus burden and the presentation of the patient as well. If the patient come less than 48 hours, so the outcome of the procedure is actually even better. Apart from uh, the, uh, the presentation timing, the thrombus burden, and also I think it depends on the expertise available at each center.
Right. Dr. Karundan, Dr. Chen, any question for Dr. Ismail?
Hi, I have one question. So thank you for your presentation. In your case, what do you think is the culprit lesion that caused the thrombosis, and what do you perform to tackle this culprit lesion? What will you do to treat this lesion?
Right. In this patient, as you can see from the ultrasound, there is a very calcified lesion at the swing segment. So this could indicate that the patient has a stenosis at that segment. So what we did was we did an angioplasty with the balloon maceration. It does not only macerate the thrombus, it also treat the lesion by using the cutting balloon and also the proba itself. So apart from treating the lesion with the angioplasty, we also use the thrombolysis and also the external massage.
Right.
Okay,
Thank you.
All right, thank
Dr.
you.
Chen?
Thank you.
Okay. All right. Thank you. So we will have a 30 seconds break, and then we will come back very soon. Thank you. Okay, so we'll continue our competition. And following Dr. Ismail, I would like to invite Dr. Ahmad Firdaus Lufti to present his case. Thank you, Dr. Lufti.
Hi, good evening. Thank you, Prof. Jackie, for the introduction and also for the panels. So I'm going to share regarding a case of acute limb ischemia following percutaneous thrombectomy of a thrombus AV fistula, the option of management. Okay, this is my outline of a presentation today. So acute limb ischemia following a thrombectomy is a serious complication that can lead to limb loss. So it can occur because of a thrombus dislodgement, retrograde propagation, or embolization. So it's really crucial to recognize the potential artery acute limb ischemia intra and post procedure. So this is a case, 36-year-old male with ESRD and also hypertension had been dialyzing through the left BCF for the past 5 years. So he came to us with a thrombus fistula for 2 days of duration. He was unable to use for dialysis. On our assessment, duplex ultrasound showed there is a completely thrombosed AVF from juxta anastomosis until the V site. So we put patient under emergency operation for percutaneous balloon maceration with a pharmacologic thrombolysis using a 5 mm high pressure balloons and O35 wire system. So we use a lyse and wait technique. We percutaneously injected 1 milligram of altiplase intravenous along the thrombus fistula first, and total given is about 5 milligram and wait for 10 minutes. After that, we use a retrograde access over the venous limb, and we straightforward goes to the juxta anastomosis that we diagnosed pre-operative using a duplex ultrasound. So we managed to POBA 5 mm balloons starting from juxta anastomosis until a thrombus area. We get a fully effaced and no recoil notice at that time. Suddenly, intraoperatively, patient complained of a numbness of forearm and also hand. So on our assessment at that time, the forearm is cold, no radial pulse palpable. The angiogram showed there is no flow distally to the brachial artery, and also there is no flow to the fistula as well. So we decided for the open brachial embolectomy, and we do the open thrombectomy. So we have two options at that time. Either we want to open at the brachial artery or over the venous limb of the fistula. So we decided to open at the region of the venous limb fistula so that we can get access to the inflow and outflow of the brachial artery, and at the same time, we do a thrombectomy over the AV fistula. So we manage clot retrieve from the embolectomy and also thrombectomy. Post-operative, patient got a good radial pulse and also the fistula trill is present. So patient was discharged home and able to cannulate the fistula 1 week later. So the discussion that I want to discuss is endovascular thrombectomy had become a standard care of the thrombus access. So under imaging guidance, not only can we remove the thrombus, but we can manage the causative such as inflow stenosis and outflow stenosis at the one setting. So the success rate is about 70 to 90%. So embolization of the arterial system during the thrombectomy is rarely and yet reported around 0 to 7%. This data I took from the Harvard Medical School and also Massachusetts General Hospital. So the presentation is the same as acute limb, 5P. So how are we going to reduce reduce the risk of the arterial embolization during a thrombectomy? This is a measures that I took from the literature that I get. So number one, use a gentle catheter and wire manipulation when initially navigating past the AV anastomosis to reduce into the upstream of the feeding artery to reduce the embolization pushing in the artery. So the number two, we should settle the clot burdens before we go to the arterial inflow stenosis. This would reduce when we balloon plasty of the venous limb, it will reduce the risk of the arterial embolism into the distally. So in general, what I noticed from this literature is that we should tackle the outflow lesion first, significantly reduce the risk of arterial embolism before we go for the inflow. So this is option of management of the arterial embolism during the thrombectomy. It could be done over the wire embolectomy. So we put a sheath, cannulate from the AV from the venous limb, put the wire, goes to the distally of the artery, and as usual, we inflate the balloons and remove the clots trawl into the venous limb. And we got an option of a mechanical thrombectomy as well. And also there are open thrombectomy. For the mechanical thrombectomy, we got the indigo thrombectomy system. So we use a suction mechanical, use a suction catheter that will reduce the risk, it will reduce the uptake of the clots distally and will reduce the propagation furthermore. Other option can be used angiojet as well. It's a pharmacomechanical.
Lufti, the time is up. So would you like us to go to the Q&A time?
Sure.
Yeah, thank you. Dr. Chen, any question?
Hi, Dr. Luthi, thank you for your case sharing. This complication. May I know why would you go for open thrombectomy directly after you see the angiogram showing there's no flow to the fistula and the upper limb? Would you consider to do endovascular thrombectomy for this patient?
Our center is have a limited budget and also resources basically. So we don't have a in-shaft over the wire percutaneous thrombectomy device basically. So we need to get from the company and get patient to pay for that. So at that time, patient already developed acute limb ischemia. So we just have that option of open thrombectomy at that time. Yeah.
Thank you. Any question? Dr. Karundu?
Yeah. Thank you for your case presentation. Maybe my question is, in your case, what do you think the cause that the thrombus from the fistula, move to the artery and make the end result of the?
Yeah, I think a learning point for me in this case is first I lice and wet it basically. So the clots is softened. So I supposed to go antigrade to do the fistulogram to see is there any distal outflow stenosis. I should have settled it first, or I should combine it basically, do a hybrid such as I reduce a clots burden first by doing open thrombectomy, remove the clots first, and then I will settle the juxta-anastomosis stenosis that causing the thrombosis of the AVF. I think the complication happened here because I laced the clots first, then I push retrogradely using push the balloons, and I think it's propagate the clots into the artery and causing an emboli to distally.
Okay, thank you.
Just one comment. Yeah, I think it's a good save. Do you in your center, do you guys use over the wire Fogarty balloon before doing the angioplasty over the juxta and anastomotic side? For my own preference is sometimes if I use a balloon that can actually allow the clot to toothpaste out. So I sometimes routinely, when I do the retrograde, I will always use an embolectomy balloon.
We do have, but it's very limited. And I'm doing this during emergency surgery. So it's not readily available. So I need to get a team, and I have no experience of doing a over the wire embolectomy basically.
Okay, I will suggest you
open embolectomy. Yeah,
very useful. But I like your discussion on the alternatives, and it's a good save. So congratulations.
thank you.
All right. Thank you very much. Dr. Lutfi, and we will go for the 30-second break. Okay, we will continue the competition, and I would like to invite our next contestant, Dr. Agi Alonsabi. Dr. Alonsabi, please start your presentation. Thank you.
Good evening, everyone. Am I audible?
Yes, we can hear you. And you can.
Good evening, everyone.
Yeah.
I am RJ Alansabi from the Division of Organ Transplantation and Vascular Surgery, National Kidney and Transplant Institute, Philippines. I will present my case entitled Excision of a Giant Arteriovenous Fistula and Access Salvage with Early Use Flexine Graft. This is a case of a 46-year-old male, end-stage renal disease patient, secondary to hypertensive nephrosclerosis, on hemodialysis 3 times per week since 2018. His access is a right brachiocephalic arteriovenous fistula created November 2018. Patient came in for progressive dilatation of the cephalic outflow with a 44 centimeter pulsatile mass with thinned out skin at the cephalic area. He had a life-threatening AVF pseudoaneurysm. Usually, this would occur when we have repeated cannulation causing vessel trauma and transmural injury. Furthermore, infection and inflammation weakens the wall, causing the pseudoaneurysm. He had a severe 44 centimeter mass with skin thinning with imminent rupture risk. For the challenges of this case, number one, a pseudoaneurysm at the cephalic vein, brachial artery anastomosis. The patient is totally dialysis dependent and cannot sacrifice the access. He had imminent rupture causing hemorrhage, infection, access loss, and death. For the plans for the patient, we had multidisciplinary clearances from nephrology and cardiology. We inserted a temporary IJ catheter, and he had preoperative hemodialysis 1 day before the surgery, where our end goal was access salvage and avoidance of long-term central catheter. The patient was scheduled for surgery. This is a preoperative photo of the patient at the operating room with the AVF pseudoaneurysm and ectatic cephalic outflow. Patient was prepped with betadine under general anesthesia, and this is the size relative to a scalpel. So under general anesthesia, a vascular control was established at the brachial artery, followed by a longitudinal incision over the pseudoaneurysm. Careful dissection was done to avoid undue bleeding, and the lesion was dissected from the surrounding structures. The cephalic vein stump was closed with Prolene 5O continuous suture. This is the post-excision photograph. We then tunneled the PTFE graft, flexine, and anastomose end to side at the brachial artery and brachial vein. After the release of clamps, we noted a post-operative thrill, and this was confirmed by a duplex ultrasound done intraoperatively. This is the patient was closed in layers, and this is the post-operative image. Just to show you how drastic the transformation was, this is just a before and after photo of the impact of the surgery to the patient. For the immediate outcomes and impact, patient is stable with graft patent on duplex. First hemodialysis was done by the graft at post-operative day 3 with the following parameters, all of which are acceptable. No hypertension, no alarms during dialysis. Patient was eventually discharged with the IG catheter removed. So this is the first cannulation done during the admission on post-operative day 3. He had no problems during hemodialysis. Graft was patent. He was sent home and was able to continue hemodialysis in the dialysis center near his residence. They were able to cannulate the graft easily and continue dialysis. For the innovation, patient suitability and impact, at 1 month follow-up, the graft is patent, no recurrence of pseudoaneurysm, infection, or thrombosis. We were able to eradicate catheter-related complications, improve functional capacity and productivity, improving the patient's quality of life. He was then counseled on kidney transplantation as a pathway to gain independence from dialysis. For my conclusion, early use grafts turn the worst complication into the best salvage, minimizing catheter dependence, improve quality of life while awaiting a kidney transplantation. Thank you for listening. Let's now go to the question and answer. Good evening.
Thank you very much, Dr. Alan Sabi. Any question from the panel judge?
Yes, I have a question.
Professor Fu, yes.
Thanks for your wonderful case. It's a very impressive one since such big aneurysms. But my question is, since you move such big aneurysms, you made such long incisions, do you consider to put adding drainages for this case? Is that safe to without adding drainage?
Drainage?
Yeah, the surgical drains in the...
Yeah, for this case, I placed a Penrose drain. But during the surgery, I did very meticulous hemostasis because I only placed a Penrose drain, which was removed on post-operative day 3.
Right. Any question from Dr. Karundin and Dr. Yong?
Hi. Yeah, I have a question. First, thank you for your presentation. So my question is, before you do so basically in this case, you do the new fistula using graft, right? You take out the old aneurysm and pseudoaneurysm. So before you create the new graft, do you consider have you performed the fistulogram, to study the central vein segment? Is there any stenotic or a problem in central vein before you perform the new fistula? Thank you.
For this patient, we did not anymore investigate if there is a presence of central vein stenosis. The patient had no problems with his dialysis throughout the 7 years in which he is using the fistula. Only that recently, a few months prior to this admission, he had this severe dilatation of the outflow near the anastomosis of the brachial artery. So for us, there is, I think, no need to investigate further for the stenosis. Thank you, sir.
Okay, Dr. Yong?
I have no questions. Really asked my question.
Dr. Chen?
Hi, Dr. Alan Sabi. So for this patient, the cephalic vein is already engorged and tortuous. So would you ever consider, say, to do just to excise the pseudoaneurysm and then straighten up the remaining part of the cephalic vein, and then say to transpose it to another subcutaneous tunnel? The patient could also use the AV graft immediately because the vein is already dilated, rather than using a graft. Would you ever consider that?
No, sir. For this case, the patient also presented with pain along the proximal length of the fistula. So the pain actually prompted him to seek consult. But during the consult, we were alarmed that he had this huge dilatation at the antecubital area, thus prompting the admission and subsequent surgery. But that can also be an option, sir, if there is no other complaints from the patient.
All right. Yeah. Thank you, Dr. Along Sabi, for bringing in these very spectacular conditions and also the surgical management. Thank you.
Thank you very much for your time.
Okay, so we'll break for 30 seconds. I'll come back very soon. Okay, we will continue our competition. And following this, I would like to invite Dr. Ann Mark to present the case. Thank you, Dr. Mark.
Hi, good evening to the panel. My name is Anne. I'll be presenting on a case of distal radial ligation, which is a counterintuitive but restorative option for distal form AVF Steele syndrome. Here we describe a case of Steele syndrome in a newly created radiocephalic AVF with resolution following distal radial artery ligation. So our patient's an elderly Chinese female, right-handed lady. A significant medical history is a known diabetic disease with retinal disease and was newly initiated on hemodialysis via the right IJ tunnel dialysis catheter for end-stage renal failure and was then referred to our service for AVF creation. Preoperative ultrasound mapping revealed significant calcified vessels with early arterial bifurcation around 3 centimeters above the arm crease and a small ulnar artery 1 millimeter in size, which are actually known risk factors to Steele even with distal AVF creation. So we opted for creation of a distal AVF to avoid the high risk of Steele likely to occur of a proximal AVF, and she underwent creation of a left RC AVF with vascular device in February this year. Intraoperatively, we noted heavily calcified arteries, and actually at 6 weeks post-operative review, we saw that the fistula was slow to mature, was poorly arterialized with a small cephalic vein lumen, but had good BA flow of 500 mils per minute. Sonographic Doppler then showed a juxta-anastomotic stenosis around 30 to 40% of the luminal caliber, as well as intravascular narrowing to 70% of the luminal caliber. So we arranged for fistuloplasty with dilatation of the narrowing to 5 mm in the intravascular lumen, as well as 6 millimeters in the juxta-anastomotic region. Significantly, no central venous occlusive disease was noted, and on retrospective review of the images, we do note preservation of the flow to the digital vessels and the pre-dilatation angio as seen in the image below. Unfortunately, clinical review 1 week post-fistuloplasty, she reported ischemic rest pain of the left hand with coolness of the entire hand, which is suggestive of a Tudor grade 3 Steele syndrome. The left hand was actually cool, but without any digital gangrene, and sensation and grip strength were intact. We confirmed our clinical diagnosis of Steele syndrome with sonographic Doppler and PPG as well. As shown here in the image, there's retrograde flow from the ulnar artery and palmar arch across the low resistance system. Here's the picture of the PPG that we've performed, which shows flattened signals on the ipsilateral hand in comparison to the right hand. We then performed angiography, which showed a paucity of flow into the digital vessels, which is consistent with Steele syndrome, as you can see in the video here. Angiography was then repeated with compression of the radial artery, which showed marked improvement in the flow to digital vessels and the EVF, which is no longer stealing from the ulnar artery and the palmar arch. As you can see, there's reconstitution of the blood flow to the digits. So at this point, I'd like to discuss some challenges in the management of a case at this point. Main considerations we had for her clinical syndrome were that we wished to have preservation of dialysis access in a newly created and otherwise functional EVF of good BA flow. The other consideration was to preserve the function of the ipsilateral hand in a very ambulant and very independent patient. Options of management that would sacrifice dialysis access or risk progression of ischemic symptoms were thus unideal. Other factors to consider are also significant pre-existing atherosclerotic arterial disease with very extensive calcifications in the arteries, as well as a very small ulnar artery. So she was reviewed clinically post angiography, and she still reported coolness of the fingers with actually duskiness of the nail bed. So we decided to proceed with interval ligation of the distal radial artery to control the inflow. We considered various options, of ligation of the fistula or proximalization of anastomosis versus observations, but all of these were less ideal options in view of the considerations we mentioned previously. So we underwent ligation of the distal radial artery in the LA with a silk. This is quite an uncommon approach to management of Steele syndrome. It's not a common scenario to be seen in distal wrist AVF, only isolated case reports in existing literature. And some options described range from, like in our case, distal radial artery ligation or embolization, or rarely proximal AV anastomosis as well. She actually had quite good outcomes, so we'll run through the immediate and intermediate outcomes for her. We reviewed her at 1 week post-op, which actually showed complete resolution of the ischemic symptoms. The left RC AVF had a good BA flow of 618 mils per minute, and dialysis was actually trialed via the AVF at this point in time. 1 month post-operatively, there was improvement in PPG signal of the fingers, as well as sonographic improvement of perfusion to the hand. So here we can compare the pre and post-intervention PPG diagrams. And here you can clearly see that on the right side, post-intervention, there's a great improvement in signal to the distal extremities here. At 3 months post-op, we did a sonographic reassessment, which showed preserved functionality of the AVF with patent anastomosis. There was no recurrence of Steele syndrome symptoms, and actually the RC AVF was able to be consistently used for dialysis access, and she was able to remove her existing pump cath in August of this year. So overall, we had quite good outcomes, both in the immediate and intermediate term for our patient, and managed to resolve her symptoms of Steele as well. So happy to take any questions at this point in time.
Thank you, Dr. Mac. Any question from the panel judge?
Hello, I just have one question. I noticed, thanks for your presentations, and you really did very wonderful and carefully assessment for this patient to make the final decision to do the procedures. My question is, I noticed that you use vascular to do the flow limitations. So is some kind of usual procedures you do for patients who need to do flow limitations?
I think for this patient, one considering we had in the initial creation of the AVF is that her vessel calibers were already very small, as well as extensive calcifications. So I think one thought was that the vascular device would help in terms of managing the juxtaanastomotic flow post during when the AVF is maturing, to hopefully try and encourage maturation of the AVF. We do know that, although Steele syndrome is also a complication of using a vascular device, the rates are very, very low, and is more commonly seen in a more proximal brachial-based AVS rather than the distal AVS. So that's why we felt quite comfortable to use it in her case.
Okay, thank you.
Thank you, Dr. Mac. So, with the hindsight that this patient, after the maturation of her RCAVF, there is a Still syndrome, basically due to the excess drawing of the blood from the ulnar circulation back into the radial and then into the fistula. So if this patient is going to rewind the clock and come to you for a fistula, would you do something differently, or you will still choose the same decision of RC creation?
I suppose this patient to begin with was in terms of her options for access were quite limited. Definitely a distal AVF would have been a better option compared to a proximal one, given her condition of her arteries. I suppose one considering we could have done is really take a closer look at the vasculature of the contralateral arm on the right side. I mean, even though that is a dominant hand, if the vessels were a bit more appropriate, perhaps that could be a consideration. But then again, if the steal had happened on the right hand, which is quite likely given that her atherosclerotic disease is likely to be present bilaterally, it would have been, I think, even more disastrous for her.
Right. Okay. Thank you very much. Any other questions? Can I also follow up on the other options? Would a proximal inflow of the fistula being considered?
Yeah, so that's definitely an option that we considered for her. But then the downside, I think, would be that theoretically it would result in a longer maturation time for AVF before use. Whereas in this case, we were able to initiate dialysis via this current existing AVF within 1 week post-op. So definitely a possibility. But I think weighing the kind of time we had and ability to regain access quite closely after intervention, I think this option was quite a good outcome. Additionally, the literature, I think, supporting efficacy of proximalization of the AV anastomosis is not perhaps quite as strong.
Okay, good. Thank you very much. I think this is a very interesting case, and thank you for bringing it to the competition. So we will have 30 seconds break, and then we'll come back again. And also in this competition, because we know that judges may be in the same division of the contestant, so Dr. Yong will be abstain from giving the score for Dr. Mac. All right, so we will continue with our competition. And I would like to invite Dr. Jingwen Ong to present the case. Thank you, Dr. Ong.
Hello, hi, good evening, everyone. I'm Jingwen, a surgical trainee from NHG Health Singapore. Thank you for the opportunity to present today. Today, I'll be sharing a case of high output AVF flow complicated by right heart failure that was successfully managed with distalization of inflow. Our patient is a 47-year-old female with a history of IHD that was managed medically, as well as ESRF on hemodialysis via a left BC AVF that was created in 2015. She has undergone multiple fistuloplasties and stenting for AVF dysfunction, significantly at the juxta-anastomotic segment, the outflow cathelic vein, as well as the cathelic arc as seen on the duplex image. Her most recent AVF intervention was in December 2024, where she underwent fistuloplasty for juxta-anastomotic in-stent stenosis. However, the lesion demonstrated significant recoil despite 2 balloon angioplasties. As such, a Covera 8x60 mm stent was deployed into the existing JA stent, followed by post-dilatation with angioplasty balloon. 2 months later, in February, she presented to cardiology with worsening exertional dyspnea and autopnea, despite achieving dry weight during dialysis. Investigations done then showed fluid overload with elevated pro-BNP and pulmonary congestion on chest X-ray. Echocardiogram was done for her, which revealed raised pulmonary artery pressures. She was diagnosed with triple vessel disease on coronary angiogram and underwent successful PCI to the RCA and LAD. However, despite the PCI done, her symptoms persisted, and she also developed a new murmur over the left sternal edge. She was reviewed in the vascular clinic in June for her routine AVF surveillance, and it was then noted that her symptoms were concerning. Looking back at her investigations, while her JAS stenosis had resolved since the intervention in December, there was a marked increase in the BA flow from 1,200 to 2,200 mL per minute over a span of 7 months, which was almost twice of the original flow. The excess flow was also elevated at 3,000 mL per minute, which has been gradually increasing since January. Notably, all her symptoms and findings coincided with the stenting that was performed in December. A repeated echocardiogram continued to show worsening pulmonary pressures, as well as a new severe tricuspid regurgitation. Overall, this picture was suggestive of a high output cardiac failure from excess AVF flow. Apart from this, she also developed a left elbow abscess overlying the JA site, necessitating incision and drainage. Intraoperatively, we noted a defect over the lateral aspect of the fistula with visualization of the underlying stent, and this was concerning for stent infection. Given the above issues, she was counseled for surgical intervention. With regards to the flow reduction, decision was made for distalization, as the newly revised AVF would require less time for maturation compared to ligation. The other concern with ligation and creation of the new forearm AVF was that the cephalic arc stent that she previously had actually extends to the subclavian vein, and this runs the risk of thrombosis after AVF ligation, which may result with outflow problem for RC AVF. Furthermore, with regards to the infected stent, she would require explantation. We did also consider bending, but this was not suitable given the presence of infection as well as the presence of prior stents. Attempts were made to insert a right IJV pump cap for dialysis in preparation for surgery, but the right IJV was occluded, hence a right femoral pump cap was inserted instead. So we performed AVF distalization with proximal radial inflow using a harvested autologous vein graft for her. First, the left brachial artery and the outflow cephalic vein were dissected and controlled. Skip incisions were made along the forearm and upper arm to harvest the vein for the conduit. The left proximal radial artery was exposed and controlled. End-to-side inflow anastomosis was made over the radial artery, with the conduit tunneled laterally over the elbow, followed by the end-to-side outflow anastomosis to the outflow cephalic vein. This was followed by isolation and transection of the JA segment. The infected Covera stent was explanted and the JA stump was oversewn. Post-anastomosis, there was good through over the conduit with excellent Doppler signal. The picture on the left shows the explanted Covera stent. Incisional negative pressure wound therapy was applied to the elbow wound to promote wound healing. Overall, the surgery was challenging with significant blood loss and high drain output on post-op day 1, which eventually settled. The drain was removed on day 2, and the incisional pressure therapy was kept for 2 weeks to promote wound healing. There was unfortunately a mild wound dehiscence on the post-op day 14 review, and this was managed conservatively with bedside debridement and healing via secondary intention. The newly revised AVF matured well and was successfully cannulated by post-op day 36. During her latest cardiac review, she reported improvement of symptoms, and a repeated echocardiogram showed reduction of the pulmonary artery pressures. The duplex ultrasound of the revised AVF also revealed successful reduction of the BA flow from initial 2,000 to 664 mL per minute. However, there was a 60% stenosis noted over the distal anastomotic site, and an early plasty was planned to preserve her AVF. During the fistuloplasty, the gram confirmed juster anastomotic and vein bypass outflow stenosis. Successful plasty of the entire bypass was performed with the final angiogram showing good luminal gain and minimal residual stenosis. She is planned for AVF surveillance in the near future. Overall, this case highlights the hemodynamic burden of high-flow AVFs, and early recognition is critical to prevent cardiac decompensation. In our case, the distalization allowed for successful flow reduction while preserving existing access for her. This is the end of my presentation. Thank you.
Very much, Dr. Ong. I would like to ask the panel judges for any question.
Excuse me, maybe I just missed some of your information. Do you use graft to do the distalization?
In this case, we use autologous vein graft for her, which we harvested from her forearm because she has an existing infection over the JA site. So we decided not to use a prosthetic graft, given that there was a presence of infection.
So is adding special ways when you do the operation, since the patient also have infection over his stents, pre-voice stents?
Yes, so there was an infection over the existing JA site. And actually, during the I&D, we noted that the stent was exposed. So during the I&D itself, as well as the operation during the distalization, we did careful dissection to try to explant the infected graft. However, because of the existing fibrosis, we were unable to excise the entire Covera stent that was inside too. But we did try to explant as much as we could. And during the distalization itself, we made careful care such that we tunneled the graft laterally along the elbow, such that it was not involved in the infected site. And also to ensure that there was no kinking of our bypass graft.
Yeah. Dr. Ong, congratulations on the very impressive resolution of the complication. I'm just interested to know if the patient does not develop a infection of the juxta anesmotic region and the Covera stent, but with the high flow and the heart failure, will it be the similar or different approach that it will manage this patient?
Our initial consideration was for the patient was actually between ligation as well as proximalization for the patient. And that was during the instance where we didn't know that the patient had any infection. So if a patient didn't have any infection, actually our stance was to use a prosthetic graft for the patient. Yeah.
Right. Okay. Thank you. May I also know that the choice of Covera for the treatment of the juxta anesmosis, what is the main indication for cover stent?
That was actually done in December, and with regards to why a Covera stent was used, the initial stent was actually a bare metal stent, but subsequently there was an in-stent stenosis. So we postulated that a Covera stent was used because of the recurrent stenosis that she had over the juxta anastomotic site, since her AVF has been created since 2015 and it was rather long.
I see. Dr. Karunit, any question?
Yes, thank you for your presentation. My question is, before you perform the distal arteries, the anastomosis to the radial artery, do you check the flow first? Because sometimes after we do the anastomosis to more distal part, the flow is not good, and then there will be a thrombosis to the fistula segment. Okay.
Prior to our distal anastomosis, we did release the inflow such that to ensure that there was a good flow prior to performing the final outflow anastomosis.
Okay, thank you. So I'd like to congratulate everyone. We've made it to the halfway point. So we will get the next presenter ready. So I'd like to introduce Dr. Karen Faye Serrano. Are you able to share your slide?
Yes. Okay. So good evening, doctors. I'm Dr. Serna. I will be presenting the multimodal surgical management of recurrent AVVF thrombosis and aneurysmal degeneration and stenosis. Our objectives for tonight are to present a case of problematic long-term HD access, to discuss various surgical management options for recurrent problematic fistula, and to be able to recognize the importance of early diagnosis and treatment of AVF breakdown. We have a 75-year-old female who has ESRF secondary to diabetic nephropathy since 2011, using her left BC AVF with ulcers and bleeding. No problems at that time until 9 years after. She had AVF thrombosis and underwent endovascular thrombectomy with fistuloplasty and stenting last 2020. The next year, her fistula thrombosed again, which thrombolysis was unsuccessful, hence a tunneled catheter was placed. Enoxaparin was given in view of her recurrent thrombosis, which successfully resumed its use for dialysis. However, this resulted to chest wall hematoma, hence it was stopped. She was able to use her fistula not until 2021 when she underwent fistuloplasty for cephalic vein stenosis, and the following year, her aneurysmal A site was bleeding, hence she underwent aneurysmectomy with primary closure. Then she had increasing V pressure on the outflow stenosis and underwent fistuloplasty. The following year, her V site had intermittent bleeding, which was addressed with suturing, and no problems were encountered after. She is known to have paroxysmal AF maintained on warfarin and had other previous surgeries. She was referred to vascular surgery for a possible phlebitis on the fistula with associated pain and occasional bleeding for the past 6 months, but was still able to complete her dialysis sessions. At the clinic, her left BC AVF was pulsatile with good thrill but with ulcers on the A and B side, with no tenderness, cellulitis, nor discharge. It was discussed that there would be a possibility that the ulcers may involve her native cephalic vein and an extensive surgery may be warranted but will lead to significant blood loss due to her intake of warfarin. Possibility of infection and the use of graft were also explained. The patient underwent left BC AVF ulcerectomy with on-table angiogram with outflow fistuloplasty, and the following operative technique is as follows. Under RA, a transverse incision done to isolate the inflow and outflow cephalic segments. Heparinization was given and vascular clamps applied. Elliptical incisions around the ulcers on the A and B sites done, involving the cephalic vein segments. Advancement skin flaps created and cephalic vein segments were repaired, primarily in double layer. Micropuncture inserted the JXA followed by a sheath, then to room up to the SVC under fluoroscopic guidance. Fistulogram showed no JXA stenosis, but with moderate outflow stenosis downstream from the V site, and a moderate outflow stenosis upstream from cephalic arch stent, with previous cephalic arch stent patent with no central vein stenosis. Angiogram showed moderate stenosis on the cephalic arch, hence a cutting balloon was used to good effect. Final run showed no residual stenosis and no spasm, and noted to have good thrill, and the BAVF at that time was at 2,000 milliliters per post-op. Intraoperative findings showed partial involvement of the A site and full involvement of the cephalic vein wall on the V site, and moderate stenosis on the cephalic arch and absence of JXA and central vein stenosis. Post-op, a temporary catheter was inserted for immediate access, and on the third post-op day, her left BC AVF was used successfully for hemodialysis and was sent home the day after. On follow-up, the patient was using her left BC AVF for dialysis with no problems. AVF is the preferred access for long-term dialysis. However, there would be problems encountered due to the anatomical changes as the fistula matures and use which would lead to stenosis. Thrombosis is primarily caused by stenosis, usually in the outflow vein, and juxtaanastomosis, which is about 70 to 85% of the time. And the proposed causes of stenosis is as follows. Because of these factors, it would result to malfunction like increasing A and B pressures, being pulsatile and tense, which would lead to eventual thrombosis. There are various ways in addressing AVF thrombosis. Open thrombectomy by inserting a Fogarty catheter to remove the thrombus, and through thrombolysis wherein thrombolytics like urokinase or RTPA can be used. Other existing problems is also needed to be addressed. Concomitant stenosis, which could be treated through percutaneous angioplasty with 90% initial technical success. For recurrent stenotic lesions on the fistula, high or ultra-high pressure balloons can be used. Cutting balloons are also available, but with a higher risk of dissection or venous rupture. Another option is a drug-eluting balloon like paclitaxel that has a patency rate of 70% versus standard POBA of 20%. Stents can be placed to yield longer patency but would limit further intervention. Comorbidities has also its effect. Increasing inflammatory markers can be seen. AFib increases D-dimer and turbulent flow will lead to thrombosis. And thrombosis is also associated with high CHA2 score in ASRF patients. In our patient, her fistula started to have problems 9 years due to the stenosis, which was addressed through fistuloplasty with stenting. Trial of anticoagulants was done, however, due to bleeding, it was stopped. Her AFib put her at risk for thrombosis, hence she was maintained on warfarin, and her high CHA2 score gave her a higher risk for thrombus formation. Her fistula had recurrent thrombosis with stenosis, which may lead to the development of aneurysmal segments. Another factor is the repeated cannulation at the same site, causing scars which may expand through time. Aneurysmal segments would result in a thinning out of the skin that makes it prone to infection, which will lead to rupture or cause significant blood loss. Symptomatic AV fistula aneurysms like bleeding due to skin necrosis and erosion, infection and prolonged bleeding after dialysis are for surgical intervention. Aneurysmography is safe, reliable, and durable procedure, and temporary catheters are advised to be inserted. In conclusion, the presence of recurrent AVF thrombosis is investigation. Being considered in patients' comorbidities, previous surgical history, AVF cannulation routine, and lifestyle. Various diagnostics and surgical options are available, and maybe conservative and aggressive types can be done depending on the perioperative process of the patient. Hence, it has a good prognosis as long as with a good proper history, anatomical structures determined, and good proper technical, the medical and surgical management would be given. Thank you.
Okay, thank you, Karen. I guess I'll start off with the questions. And can I ask for the aneurysm revision? How did you close the vessel wall of the AVF? And what are the other alternatives that you're aware of?
For this patient, we use a primary closure using we use it under closure 2 layers. Other closures could be we can use grafts, or if there would be no enough wall segment to use to be able to close this the aneurysmal segment, we can always use grafts or even bovine grafts also, or even from different area sites or autologous grafts like the vein, IJ or basilic vein.
Okay, thank you. Can I invite the rest of the judges to give any questions? Dr. Chan or Dr. Fu or Prof. Ho?
Dr. Serrano, I think the cases that you present is very challenging, and thank you for giving a very nice solution for the patient. I just like to know, when you perform the surgical aneurysm rectification, is there any specific precautions so that the patient actually can use the fistula that being reconstructed nearly immediately after the procedure?
We should make sure that the involved cephalic vein wall will be free of any signs of infection, and it would be big enough upon closure to be used again as a new fistula for it to be properly used as soon as possible.
So is the surgical scar over the fistula, or it is being tunneled to a subcutaneous slightly away from the surgical scar?
Usually do our incision slightly away so that when we close, we won't be affecting the cannulation sites.
Okay, thank you.
Thank you.
Any other questions?
May I also know that in this patient, what is the size of the fistula after the rectification? Roughly, how big is the fistula?
Roughly around 6 to 7 millimeters after. Because we wanted to have the same size almost with the stent also that was previously placed a few years back.
I see. Yeah. Thank you.
Okay, thank you, sir.
Okay, if there are no questions, then we will give the judges some time to do the scoring. Thank you, Karen.
Thank you, doctors.
Okay, we would like to invite the next contestant. So this is Dr. Louis Y.
Hi, good evening, everybody. Thank you, judges, for your time today. My name is Dr. Louis Y, and today presenting a case of a high flow fistula who underwent a Rudy procedure. So a high output fistula is a high flow AVF, whereby the blood flow is more than 1.5 liters per minute, or the blood flow cardiac output is more than 20%. This may lead to high output failure, left ventricular hypertrophy, pulmonary hypertension. So our patient is a 54-year-old, very skinny lady with significant comorbidities of ESRF, hypertension, as well as ischemic cardiomyopathy, EF of 30%. Her access was created in 2021. It was a BB-AVF, which required limited superficialization prior to AVF cannulation. So in January 2024, she presents to clinic with worsening left hand pain and weakness. There was no shortness of breath. There was no increase in effort tolerance. Because of the symptoms, an AVF scan was done which showed that the brachial artery flow was 2.8 liters per minute. She was offered bending as high flow due to for high flow due to the risk of high output cardiac failure. She underwent bending in March of 2024. It was done with assistance of endovascular support, retrograde puncture on the basilic vein using ultrasound, and then bending was performed using a balloon 6 by 40 mm to size. It was finally bended with a 6 mm PTFE strip, and the BA flow reduced to 1.5 liters at the end of surgery. However, in August 2024, she presented again for a few issues. Number one, there was high V pressures, which initiated the referral back from renal. It was about 180. We worked it up with an AVF scan and CT venogram, but then there was no stenosis seen. There was also high recirculation. This was thought to be due to a limited cannulation zone as the A and V needles were too close together. And there was also pain on cannulation during dialysis because it was thought that the cutaneous nerve was very close to the vein. And lastly, we noted that the BA flow was very high again at 2.6 liters per minute. And patient at that point of time had early symptoms of right-sided heart failure, shortness of breath, and she also had problems climbing up one flight of stairs. So in September 2024, she underwent revision using distal inflow and superficialization of proximal segment of basilic vein. We did an elbow transverse incision to control the proximal brachial artery with vessel loops, and also did a forearm transverse incision over the mid-radial artery to isolate the radial artery. Then after that, we did a left upper arm medial incision, longitudinal along the basilic vein forearm medial bunch. The medial bunch of the basilic vein was dissected, and then the AVF was transected distal to the segment joining into the medial bunch. This vein was tunneled laterally to join the radial artery at the mid-arm. and end-to-site anastomosis was performed with proline 70. Thankfully, there was this basilic vein side branch. Otherwise, we would have to use a prosthetic graft. So intra-op, the basilic vein was 5 mm post-hydrodilation. The radial artery was 3 mm, and the anastomosis size was 10 mm. Patient was very well and discharged on day 3 post-op. So how did this surgery help with our patient's issues? Number one, the superficialization of the proximal zone of the AVF helped to avoid the cutaneous nerve in the arm and also helped to optimize the cannulation zone, as the A and V needles were too close, leading to a high rate of recirculation. And secondly, we also addressed the problem of high V pressures. As this was a very, very skinny patient, it appeared that cannulation done in the dialysis center was the patient's vessel that was cannulated was actually the brachial artery rather than the brachial vein, which caused high recirculation. And lastly, our Rudy also helped to reduce flow reduction in this patient and prevent complications and address complications associated, such as shortness of breath in this patient. So she was seen post-operatively at 4 weeks, and then the trial was good. The BA flow was reduced to about 1 liter per minute. We noted a swing point about 60 to 70% stenosis, and we discussed fistuloplasty to optimize outflow. So in November 2024, we did a BB fistuloplasty for her. There was a tight stenosis over the outflow at a swing point about 80%, and this was a balloon sequentially up to 8/60 to full effacement, and then a drug-coated balloon was also used. So these are the pre-fistuloplasty and post-fistuloplasty grams. So patient is currently well and being able to dialyze in the community. Thank you very much.
Do the judges have any questions?
Dr. Wei, thank you very much for the very interesting case, and I think it is really quite challenging and not frequently seen condition. Actually, I would like to know from the beginning, because you mentioned that this patient is relatively slim and she is having a basilic vein fistula, brachial basilic vein fistula. So I just wonder like why the cannulation zone is very limited for a slim patient with the basilic vein.
We actually think that's maybe due to the swing point or the branches of the basilic vein, which were not very apparent at that point of time. And the nurses may have been cannulating the brachial artery instead of the brachial vein, which actually led to all these complications, such as the high V pressures and high V circulation.
Right. And is it also relating to the bending procedure being done? Has the bending procedure like shortened the cannulation zone, or it is not really affecting the cannulation zone?
We think that the bending procedure did not really affect the cannulation zone. The issue with the cannulation zone is that we think that it was actually patient was experiencing a lot of symptoms of pain during cannulation, and we think that there was probably a nerve that was lying very near the cannulation zone, and it's not anything to do with the bending procedure.
Okay, I see. May I also ask, when you're considering to distalize using the radial artery as the inflow, what would be the criteria of the size or the wellness of the radial artery that you will consider using it?
So for this case, we would think that the radial artery will likely to be about at least 2 to 3 mm in size, and avoid any areas with obvious calcifications, which may make the anastomosis more tenuous.
And how about the distance? I mean, will you use a proximal radial artery or like a mid-forearm radial artery?
For this case, I think that the radial artery location to be used would likely to be a bit more distal due to the high volume flows that the patient was experiencing. But also, we are also limited by the side vein, the length of the side vein that was present. Luckily, there was a side branch of the basilic vein which we were able to use. Otherwise, we would have to use a prosthetic graft to join up to the radial artery in order to achieve sufficient length for the procedure to be done.
Thank you.
Thank you. I think thank you, Dr. Y. We'll let the judges finish up with the scoring. Okay, so I would like to introduce the next contestant, Dr. Joseph Shi from Taiwan.
This. Okay.
Dr. Shi, yeah.
Yes, can I go? Okay. All right. Good.
See your slide.
Thank you. Thank you. Good evening, ladies and gentlemen. My name is Dr. Joseph Shi, speaking to you from New Taipei City in Taiwan. Today, I will present a case of central vein stenosis in a dialysis patient with underlying zone 1 TIVA and CCS bypass. So this is a 51-year-old uremic patient who suffered from acute aortic dissection in 2022. Zone 1 TIVAR with carotid subclavian bypass was successfully performed. However, the clinical course was complicated by stroke with right-sided paraplegia and right renal failure. The patient has been on routine hemodialysis for about 3 years via a right brachiocephalic AV fistula. Now, progressive swelling of his right arm and chest for several months have occurred, and eventually it developed into right hand numbness, cyanosis, and chest and pain of the hand consistent with compartment syndrome. The patient was initially referred to interventional cardiology, where angiography showed total occlusion of the right subclavian, brachiocephalic, and jugular veins. After several failed attempts at recanalization, the patient was referred to our cardiovascular surgery department for treatment. We performed a CT on admission and determined the type of central vein stenosis. In this image, we can clearly see the CC bypass, carotid bypass, the carotid subclavian bypass, the obliterated right internal jugular vein, and the extensive collaterals and soft tissue swelling in the right chest. Total occlusion of the right brachiocephalic vein with tight stenosis was found with suspected external compression from the right brachiocephalic artery. The Society of International Radiology classified thoracic central vein stenosis into 4 types based on the extent of the obstruction. And this case is a type 2B with right brachiocephalic obstruction and known patency of the contralateral side. So our challenge here is how to quickly relieve the compartment syndrome of the right arm and hand while preserving the right native brachiocephalic shunt. So what options do we have? But first, I would like to try to convince you that compartment syndrome can occur from AV fistula with central vein stenosis. Our colleagues in Taiwan published a paper in 2013 demonstrating such a condition. This is a 52-year-old Urmic woman with right radial to cephalic fistula presenting with right arm swelling, numbness, paresthesia, and skin changes consistent with compartment syndrome, as you can see in figures A and B. Now, a cephalic axillary junction stenosis was found, as you can see in figure 1, and post-dilatation in figure 2. Now, the condition relieved significantly after about 3 days, as you can see in figures C and D. So the endovascular treatment options we have include aggressive recanalization of the central vein stenosis using various methods of sharp recanalization, or sometimes palliative approaches such as balloon-assisted banding and simple access ligation. Thus, we attempted echo-guided puncture of the right internal jugular vein, but this was met with difficulty as the neck was swollen and the vessel was obliterated. So we attempted echo-guided access of the cephalic arch and the right subclavian vein, but in order to provide firm support for sharp recanalization of the occluded brachiocephalic vein, but this also failed. So what about palliative approaches? We considered banding, but banding is a feasible option for correcting arm swelling in patients with high flow shunts with good venous flow. Now the problem is this patient does not have good venous flow, so in shunts with significantly compromised venous flow, banding is not recommended. Other palliative approach included access ligation. Now this would have been our first treatment option, followed by tunnel catheter insertion and a new AV access creation of the left arm. However, following zone 1 TVAR, we felt that a new left arm AVF should be avoided since blood flow from the right common carotid may not be sufficient to accommodate arterial demands of both carotids and the left subclavian and a functional left atrioventricular shunt. Now, of course, the femoral AV access can also be considered if all the upper arm options fail, but we thought that we did not want to consider this at this time. So maybe for later in his clinical course. So what about salvage procedures? The HERO graft has gained much popularity in recent years, offering feasible option for patients with occluded central veins. Again, our right jugular access was not feasible, so we would consider retrograde access via the right common femoral vein using the surfacer inside-out technique. However, this technique is not without potential risks for bleeding since the patient is still on aspirin for his old CVA. This is the image describing the HERO graft inside-out technique, but of course this is not without complications. Furthermore, we are not still not ready to abandon his right upper
about 30
arm.
seconds to
Okay.
would you be able to like show what you have done for the patient?
Yes. Finally, we considered the final salvage procedure, which was the extra anatomical bypass. And as published in 2013, this is actually a very durable and good option. So ultimately, we performed a right axillofemoral bypass for the patient with 8mm Gore-Tex graft. And the shunt function remained intact, and the rapid regression of the arm was witnessed. Thank you.
Thank you, Joseph. I have one question, I guess, because you are cardiothoracic surgeons in Taiwan. Open options available for this patient besides a long axillofemoral bypass?
Yes, we also considered the axillary venous bypass, but we sort of avoided it because the previous CCS bypass causing extensive adhesion to the left subclavicular region. The actually femoral bypass was not our initial intent, but because of all the failed interventions that, the endovascular interventions, and we really wanted to preserve the patient's native vessel because he was young, although he had a stroke, but he was still active. And so we wanted to preserve his upper arm native vessel. And that is why we considered the axillofemoral bypass for him.
And if this axillofemoral bypass blocks off, would you consider anything more invasive? You read in the textbooks or even go into the chest?
Yes, this is a very good question. So we made the little search on the durability of the graft, and it's actually pretty durable because for first intervention to be needed, it takes about half a year or so. So we think that we should be able to maintain assisted patency quite well for this patient. But in the future, maybe if the graft actually fails, we can consider such as hero graft for the patient.
Thank you. Any other questions?
Excuse me, I'd like to know any anticoagulations you described for this patient after the procedure.
Yes, thank you for your question. The patient actually has old CVA after his zone 1 TVAR, so he is already on aspirin daily. So I did not add any additional anticoagulation for him.
Dr. Shi,
Yes.
just like to, for discussion, would you consider a endovascular extra-anatomical bypass from the, say, SVC or maybe a partially stump over the right brachiocephalic vein to the patent cephalic vein of the patient?
Okay, this is actually a very good concern. After zone 1 TVAR, we are very cautious about intervening with the SVC and in the area close to the right brachiocephalic artery because it is so vital to the patient. So we didn't do such too aggressive intervention for the close to the region, including the brachiocephalic vein and the retrograde cannulation from the femoral. So I guess I would not consider because of the importance of the brachiocephalic artery to this patient. Thank you.
Okay, thank you very much.
Okay, we will come to our next contestant, Dr. Wasiti Ajanakiti from Thailand, Prince of Songkla University.
Good evening, everyone. I'm Wasiti Yatanakiti, the second year fellow in Interventional Radiology at Prince of Songkhla University, Thailand. It's my honor to have an opportunity to present you the case of dialysis access complication in related with thoracic central vein today in the title of endovascular correction of a migrated stent in the superior vena cava in a hemodialysis patient. I would like to give the courtesy of this case to my senior consultant, Associate Professor Kiruti Hongsukun first. The patient is 55 years old male with ESRD on hemodialysis via right brachiocephalic AVF, who had history of right brachiocephalic vein occlusion before. On 10 January 2022, he was successfully done the procedure of sharp recanalization with transeptal needle. Post-recanalization balloon dilatation was applied up to size of 16 mm, 40 mm long. He was scheduled to follow up at next 4 months when he presented with symptoms of central vein stenosis. On 10 May in the same year, venogram review focal severe stenosis at right brachiocephalic vein, as you can see. The percutaneous transluminal venous angioplasty was done with balloon size 60 mm, 40 mm long at right brachiocephalic vein. However, venogram post PTVA also revealed significant recoil stenosis. So the team decided to stent sinus XL stent 60 mm inside 30 mm long was applied to right brachiocephalic vein. But unfortunately, there was distal migration of the stent into distal SVC-RA junction immediately after stent deployment. The complication occurs to the patient that time here under local anesthesia. So the IV sedation was given to the patient. Then to correct this challenge complication, the decision was made on attempt to relocation the stent by snare. After the team quickly made a helping route at right common femoral vein, the first snare was applied to this approach, like this. Because the stent was right there floating, after capture the proximal edge of the stent, the snare could pull the stent upward to proximal SVC, but it's no further than that area. So another snare was applied to right cephalic approach, capturing the proximal stent also, like this. A bit of pulling force was done via the right cephalic route. However, the patient experienced that he could not tolerate the pain more, and that was the exact time when the stent appeared to be deformed. So the snaring was stopped. The single shot image that you can see clearly demonstrates deformed stent. It just looked like a barrel one. The procedure with complication was more right now challenged by the deformed mid-place stent. One of the options to correct this situation that the team was thought about at that time was trying to re-stenting with another stent. So the PTVA was again done with balloon 16 mm, or 16 mm, 40 mm long to stabilize the position of the deformed sinus AL stent first via the right cephalic route. During balloon inflation, you can see one of the snare from right femoral root was still capture the proximal stent until the team had a confidence that the stent will not migrate anymore. Then the snare was released later. After inserted the long vascular sheath, the restenting by sinus venous 16 mm, 80 mm long was done along right distal subclavian vein, right brachiocephalic vein down to superior vena cava, followed by post-stenting balloon dilatation. The venogram procedure revealed imposition of the second stent with patent of the treated segment, and finally the top situation resolved. About the follow-up, he has no problem of his circuit use. The patient can apply regular hemodialysis via the right brachiocephalic circuit until now. The latest follow-up venogram that we had is on 4th of February this year. It shows moderate stenosis at intrastent at right brachiocephalic vein and focal moderate stenosis at cephalic arch and right subclavian vein that he was successfully treated by PTVA at all the aforementioned site already. Thing I have learned from the case, first, patient preparation can prevent the complication and facilitate SAWAT procedure, such as if we put him under general anesthesia, the SAWAT procedure may went more smoothly. Second, knowing things in yourself could help you making proper decision for SAWAT the patient. And there may be other choice of SAWAT procedure that should consider apart from relocating the stent, such as snaring the stent out or tapping the stent at proper site or others. So learning other SAWAT procedure could help in complicated situation. Thank you for your attention.
Thank you, Dr. Wasiti. Any questions from the judges?
I
Understand? You first.
Okay, thank you. So yeah, my question is, based on your case, what do you think the cause that, affecting the stent migration?
Yeah, in this case particularly, I think it's because the stent itself, because the team maybe try to apply the stent that very focal stenosis one, so they choose the stent that that short one. So maybe if we try to not to gel to other side of left microcephalic vein, it's a problem that we can hold it with the very focal one, I think. Yeah.
Yeah, thank you.
Thank you for the question.
For my opinion, the stance you first use is too short, so it's very easily to move. But I noticed that since the second stent you use is still a bare stent, right?
Yes.
So I don't think that's the reason why they not to cover the
Another bear, right?
jungle. Yeah. So I maybe they just want to put a short stands there, but
Yeah.
it's very dangerous. But I worry, since if we met this kind of situation, we would like to pull the stent down to the iliac phase. So why you trying to push it up?
Yeah.
Since it's really very
Yeah.
not that easy to do so.
I also think about that once I made this case in follow-up time. But I think at that time, the patient is not under general anesthesia, and the team may be just afraid of the stent when it coming down to right atrium. And the patient, at that time, he have a severe pain already. So they don't want to face more complicated procedure like pulling down and giving a big sheet, larger sheet, right? And put it out from trapping in the iliac or maybe coming out, taking it out. So I thought at that time they afraid to do another procedure on not quite prepared patient. Yes.
Dr. Wasiti, very nice case. My colleague will call it a stent insufficiency syndrome. So it's very daring to put one stent again after the last stent. One question. What are your considerations, at least in your center, when you would do central venous stenting for central vein stenosis?
Okay. With the central vein stenosis one, you can see in this case, he have done sharp recolonization before, right? But we decided not to put the primary stenting at that time. We not routinely put the stent first, but we will follow until we assure that maybe the significant restenosis occur. Then we will put the dedicated venous stent rather than the stent that designed for the arterial one that have more radial force. But in the market of Thailand, maybe we have the listing to choose. We just have the sinus venous one at that time.
Okay, thank you.
Thank you.
So we'll wait for the judges to put the scores. Okay, the next contestant is Dr. Yo Chan
Yes.
from University Hospital.
Okay, good evening, everyone. I am Khwanchanok Yoshum. I am a vascular surgery fellowship from Thammasat University Hospital, Thailand. I would like to present case with rare but devastating complication, which is band infection after flow reduction procedure. So the left BC AVF was created for a 57 years old man. After lost follow-up for 3 years, he came again with the last aneurysmal chain of the AVF. And he also had severe pain at shoulder during the dialysis. The duplex scan shows cephalic arch stenosis. The entire cephalic was about 15 to 20 millimeter, but the cephalic arch stenosis is about 5 millimeter. And the volume flow was high, about 2,000. So according to ASVS guideline, when we have both high flow and cephalic arch problem, we do flow reduction procedure first, and that's what we do. We decide to do precision banding with PTFE graph. Intraoperative real-time ultrasound show flow about 800 ml per minute. So after that, we do transfix suture at the PTFE graph. 1 week after banding, the patient has uneventful recovery and normal hemodialysis session, no more pain at the shoulder. So we plan for 6 months follow-up. But unfortunately, the patient came to the ER earlier with bleeding AVF after 1 month of banding. He started have erythematous skin for 2 weeks and pus from wound for a week, but he'll still have normal hemodialysis. So the bleeding AVF was sutured at the ER. The physical examination shows skin erosion near previous surgical area, and the ultrasound shows pseudoaneurysm near banding area, and again, the cephalic arch stenosis about 4 millimeter. So we observed several problems here, which were bleeding pseudoaneurysm, suspected band infection, high flow AVF, and a cephalic arch stenosis. Our thought was that the pseudoaneurysm was caused by the PTFE band erosion and causing infection. So our consideration was to stop bleeding first, then preserve hand perfusion, preserve the access, and prevent the long-term complication, which is high flow problem and the cephalic arch stenosis problem in this case. So we proceed the patient to OR. After proximal control at the brachial artery with clamp and the distal control at cephalic vein with the compression, manual compression, we encounter the bleeding area and suture proximal cephalic vein near anastomosis. Then remove the band, PTFE, and the necrotic tissue. After we control the bleeding and clear up the infection tissue, there was clot along the entire cephalic vein due to the manual compression. So the clot was milled out from the cephalic vein. Our plan is to preserve this access by anastomose new AVF by anastomose the cephalic vein to more proximal brachial artery, and also not to leave the cephalic arch stenosis problem behind. We like the cephalic vein just distal to the stenotic point and transport it to the brachial vein as a new outflow. And this is the picture from our real case. So we plan to do cephalic vein transposition to the proximal brachial artery as a new AVF anastomosis, and the proximal, we just disconnect, just distal to the stenotic point. But we have one more problem right here. According to the history of high flow AVF, The cephalic vein here is about 20 millimeter. So we need AVF anastomosis to be only about 4 to 5 millimeter to prevent Steele syndrome and prevent recurrent high flow problem. So we use vein tapering technique to deal with the large cephalic vein to reduce vein size from 20 to 5 millimeter before anastomosis with the brachial vein. This is the illustration showing vein tapering technique used in femoral vein transposition. So this is a photo from our case after vein tapering technique was done. With this technique, we reduce the size of anastomosis without leaving any prosthetic in this infected area. The alternative choice would be plication or redo banding or interposition graft, but it's still too high risk for infection in this area. So this is a summary of the case. And despite of everything, we preserved the cannulation zone. So all the problem was solved, and there is no switching to catheter as we were able to preserve the cannulation zone. Intra-op ultrasound showed volume for about 400, and the patient had uneventful recovery and discharged in 1 week. He's cured from the infection and never had flow problem again, and never had outflow stenotic problem again during this past 2 years of follow-up. His last duplex ultrasound performed last month showed volume for about 900. So from our experience with this kind of case, we need to step approach each problem. And we have situation with bleeding, pseudo aneurysm, we stop the bleeding first. After that, we preserve hand perfusion. In some cases that have limb threatening, we might need to ligate the access and not be able to preserve. Then not to only to preserve the access, but the best would be preserve the cannulation zone so the patient doesn't need to switch the hemodialysis to catheter. And the last but not least, we do our best to prevent long-term complication. The vein tapering technique helps to avoid large anastomosis that can cause recurrent high flow problem, and the technique also help not to leave any prosthetic behind, like other flow reduction procedure, especially in infected area like in this case. So in summary, is a rare complication, but fortunately in this case, we were able to achieve a good outcome after treatment. Thank you.
Thank you, Dr. Yocham. We'll open the floor to questions from the judges.
Yes, please.
Dr. Yochan, it's really a very nice case, very challenging, and yet I think the solution that you have presented is really a very nice solution for this patient. Just wondering, what is the bacteriology of the infection, and how do you manage the infection perioperatively?
Firstly, we try to send the tissue culture, but it's no growth. And also we send hemoculture, it's also no growth as well. We send the band also, the band tissue, the PTAV graft, but it's also no growth. So the thing is the patient got some partially treated antibiotic, oral antibiotic by himself. So that's why we missed the opportunity to diagnose the bacteria that caused this problem. And before the procedure, we give an IV antibiotic. We give augmentin at that point.
Right. Okay. Thank you. Do you give the patient like a period of oral antibiotic to maintain over the perioperative period?
The first operation, which we do banding procedure, we give a cefazolin before the operation, and after that we give oral antibiotic for 1 week. But I think this patient said like he didn't do wound care quite well, and he said actually the wound is getting worse after that first week of follow-up, but he didn't come to see, so it's a little bit late. So that's why the infection is worse than it should be. And this procedure, the patient, after this second procedure, the patient was admitted for IV antibiotic for 7 days and then discharged.
Thank you.
Thank you.
I'd like to congratulate Dr. Yocham on a very innovative case.
Thank you.
Any other questions?
Hi.
No question, just some comments. Thanks for your picture is really very nice to clearly explain what you do. Very good ones, thanks.
Thank you.
One question for me. Thank you for your presentation. Really nice case. So maybe my question is, yeah, is it common to, for this case, when infection to occur, in using in band using graph in your center, or is this only, one case?
Sorry?
Yeah, my
I
question
think
is,
BT is asking that
yeah,
you get banned in your center.
Oh, I asked my professor, he said like he usually find it like less than one case per year. So it's quite rare in our center.
So for bending, do you prefer to use like this graph, or like, for example, only with stitches?
We usually do with pretty heavy banding, and we usually give the length about 1 centimeter to give enough length to make the vein smaller.
Oh, okay.
Thank you, Dr. Yo Cham. Stop for grading. Dr. Yo Cham will be also presenting the next case. She has 2 cases.
Yes, it will be me again. Should I proceed now or have some break?
You have a break. Give us about 30 seconds, so 1 minute.
Okay.
Okay, I'd like to introduce Dr. Yo Cham, who will be presenting her second case today.
Okay, good evening again. It's me again from Thailand. Today, the second case is I would like to present the recalcitrant stenotic AV graft needed bypass in infected arm. So this is a 66 years old man with history of multiple failed AVF on both arms and history of left brachiocephalic vein stenosis. The left loop arm AV graft was created at Otto Hospital 6 months ago, and he started having left arm swelling in few months after start using it. So the recurrent central vein stenosis was suspect, the CTV was sent, and it shown severe stenosis of left brachiocephalic vein. So the patient was sent to interventionist for balloonoplasty, and the BCAVF stenosis was treated. 1 month after procedure, the patient visited again with recurrent arm swollen. The duplex ultrasound showed venous juxta-anastomosis stenosis with pseudoaneurysm near venous cannulation zone, about 2 centimeters in size. So we planned for elective surgery. At that time, the patient still didn't have a sign of infection of the arm. But while waiting for the operation, he developed left arm cellulitis. The arm was marked swollen, led to skin crack and wound infection. The patient was admitted for IV antibiotic and planned for urgent surgery after infection improved. There was a difficulty in a cannulation, so he had to do a double lumen catheter at the right femoral artery as a temporary use. So these were several problems: the venous juxta-anastomosis stenosis, the pseudoaneurysm, the recurrent brachiocephalic vein stenosis, and the skin infection. About 7 days after antibiotic treatment, the skin infection was improved, so we proceeded the patient to the OR. We puncture at the ileum, and this is the first venogram show marked stenosis at venous juxta-anastomosis. So we pass the stenotic lesion with 018 wire. The brachiocephalic vein show again the moderate stenosis. Sorry. This. And this is the pseudoaneurysm right here. The patient said is enlarging about 1 month. So we start using the semi-high pressure balloon and the high pressure balloon to balloon the venous juxta-anastomosis stenotic lesion, but it's failed to open the lesion. So we escalate to the cutting balloon, but again, it's still not able to open the lesion. And you can see here the stenotic lesion was improved, but still have more than 50% residual stenosis. So our plan was to do bypass across this lesion. But we have several considerations right there because we are on local anesthesia. We need to switch to general anesthesia if we want to do it, but it's not feasible at that point. So secondly, we think about alternative beside bypass. Is there any other option? We already use balloon escalation strategy, but all the balloon failed to open the lesion. And for stent, I think stent is not able to open the lesion as well. And to leave the stent in that severe stenotic lesion might fail entire AV graft by causing thrombosis. So we decided to stop the operation right there and plan for urgent bypass. In the meantime, the patient was able to use the hemodialysis to the AV graft, and the femoral catheter was able to be removed at the 7th day of use. Now it's come to the conduit consideration. And the best option would be native vein, as we know, but this patient doesn't have suitable conduit. The synthetic grafts that SPTAV graft could be high risk in infection. So in this case, we consider using biological graft. In this case, we use collagen vascular graft made from bovine carotid. So we proceed the second operation a few days later. After balloon venoplasty at left brachiocephalic vein, the significant recoil was shown. So we decided to put the venous self-expandable stent, which is Arbre. And then we put the cover stent at the pseudoaneurysm, and then we do interposition graft. Firstly, we use ultrasound to identify the good inflow and the good outflow. And this is the interposition graft between V-limb of AV graft to the healthy proximal brachial vein. So this is the summary of the case. We treated all the problem by using hybrid procedure, as I described earlier. Sorry, I didn't have the picture from fluoroscope because our C-arm was running down after the case. And the patient had uneventful recovery. The wound at left arm was healed, and he has normal hemodialysis after that. It's been only about 2 months after the surgery, so the long-term outcomes still need to be observed in this case. So the learning point of this case, firstly, there is one important thing that we could learn, that this AV graft was created without knowing history of BCV stenosis. This is why we should review history of previous vascular access, and especially the history of central vein stenosis before creating new access to prevent this unfortunate problem. Second, after we fail endovascular treatment, it's okay. Bypass is still a good old friend to deal with the residual severe stenosis lesion like this. And conduit is one key of success. Using vein graft would be ideal, but in some patients that have unsuitable vein and high-risk infection, biological graft could be a good alternative conduit. But there is a big note here is about the price of it. Using all this venous stent, cover stent, biological graft are expensive. If it's not suitable in some patient, the alternative would be open surgery for every problem, which is cause longer operation time, and the patient needs to be more fit as we need. And also, as we need to use synthetic graft, the operation might need to be postponed until the wound would heal, and it might need longer hospital stay and longer time of catheter use. So in this case, the patient had exhausted all upper extremity, If this access failed, he might need to do lower extremity AVF or long-term catheter. So we did all we could do to salvage this access. Thank you.
Thank you, Dr. Yo Cham. Questions from the judges? Dr. Fu, Dr. Shan?
When you do the when you do the bypass, the new graft is end to end or end to side?
The end of the graft, the end of the biological graft to the side of the AV of the first AV graft and on the side to the brachial vein, so end to side.
Okay, but I just in my opinion, since that is also a graft, maybe end to end will be more easier for the further parentheses. Just my opinion.
Thank you, thank you.
Dr.
Can I
Yong.
ask if
Oh, sorry.
Oh,
You go first.
Oh, I just wanted to ask, after the final angiogram before the bypass, was there any consideration to do a vein patch? Or was there enough length to try to distalize the anastomosis, or proximalize the anastomosis before doing something like a bypass?
It's quite severe stenosis, and this arm at that point is quite big because it was like an infected arm, and that area near the anastomosis has lots of fibrosis. We are trying to dissect the vein near the anastomosis, but it's not possible. So it's better to use ultrasound to identify the good healthy vein and bypass to that area. I think that's better at that point. That's why we use the more proximal brachial vein as the new outflow.
Thank you.
Dr. Yong Cham, I just wonder for the graft vein anastomosis and the outflow vein stenosis. I understand after the angioplasty, the result showing some recoil. Would you consider an endovascular solution of a stenting compared to the using the biological graft? How would you compare the two?
Sorry, in this case, it was not a recoil. It's the residual stenosis. It's not open at all. We use the high pressure balloon. We even use cutting balloon. It's not open. And you can see there's still waste after we use cutting balloon. And this is the residual stenosis we have left after the procedure. So when it's come to residual stenosis, if it's recoiling, we will put stent for sure in this case. But this is a residual stenosis. I think when you put stent in the residual stenosis, I don't think it will open more than a high pressure or more than a cutting balloon. So I think it's no benefit to put stent on this kind of lesion. That's our opinion at that point.
I see.
And another question, that since you already use a new graft, biological graft, why you just put some segment to the pseudo aneurysm parts?
Actually, we were thinking about that as well, to bypass to even more proximal to the pseudoaneurysm, but I think longer bypass in compared to shorter bypass graft, but shorter bypass graft might have better patency, and also we don't want to dissect more in the recent infected arm, so we want to do as short as possible at that point.
Dr. Yong Cham, I think Professor Fu means use part of the graft to patch repair the pseudoaneurysm.
Yeah.
So we didn't want to enter that area of the arm because it's quite swollen, as you can see. So at that point, we didn't thinking about open repair. But yes, that could be the alternative, cheaper option, as we use that graft, that biological graft anyway. Thank you for the opinion.
Thank you for your case.
Yeah, in Singapore, if Conquest doesn't open, the vendor says that you can get your money back. So I hope you got your money back. But, yeah.
Thank you. Is there any more question?
No questions. Thank you, Dr.
Thank
Yota.
you.
We'll take a break to do the scoring. Thank you everyone for staying back. So we have 2 more participants. I'd like to introduce our next contestant, Dr. Manoj Hambadi from India.
Yeah, sir. I'm audible, sir.
Yes, Dr. Manoj.
Yeah. So, good evening, all. I'm Dr. Manoj Ambade from Star Care Hospital, Kerala, India. So, I'm here to share our experience regarding the plain balloon angioplasty for the salvaging the thrombosed aneurysmal upper arm dialysis access. There is no as a proper definition for the aneurysmal AV access, but we considered it as a when it is more than twice the adjacent normal fistula vein segment, and the incidence of the aneurysmal AV access is also very variable. As we know, the thrombosed axis is formed due to high pressure flow followed by shear stress into the fistula vein, which causes the endothelial damage, leading to the neointimal hyperplasia, causing the stenosis, which leads to the thrombosis ultimately. When aneurysmal AV axis get thrombosed, it is challenging to get it salvaged because of large thrombus load into the fistula vein. And options are patient might need a open thrombectomy or a prolonged thrombolysis, and use of recently introduced mechanical thrombectomy devices, which are costlier one. But for the Indian scenario, we have opted a cost-effective method of plain balloon angioplasty. The basis of our procedure is optimal treatment of the culprit lesion, which is a stenotic lesion, and balloon maceration of the thrombus. So this is one patient of a 47-year-old male with right-sided basilic vein transposition, presented with 1-day history of absent thrill. We have confirmed the diagnosis with the ultrasound, and usually we keep these patients on temporary dialysis catheterization after this presentation, and we plan the daycare procedure for the access salvage with the plain balloon angioplasty. We usually do the mapping of the thrombus fistula vein in the assessment time to mark the vein size and the artery size. Artery size is important to get the puncture, to plan the puncture, to get the adequate, to know the adequate length of the brachial artery from anastomotic side to bifurcation. So we usually do the brachial access under the ultrasound. But for this particular case, due to the short length of brachial artery till the bifurcation, we have done the proximal radial artery puncture near the bifurcation. Commonly, we use the 6-fin sheath. So in this case also, we have used the 6-fin sheath. But when the fistula size is very much large, we have used the 7-fin sheath, radial sheath also. So this is a check angiogram. You can see the no flow in the fistula with a small stump at the anastomotic site, which is may or may not be seen every time, and retrograde filling of the artery. Ultrasound is commonly used by us for engaging the access anastomotic site by using the 5-French KMP catheter. Followed by, we cross the occlusion with the 035 thermohydrophilic guide wire. The looping technique is usually used by us. Then the wire goes into the central vein, and we usually park the wire into the IVC. So choosing the right balloon after crossing the wire is very much critical. We don't consider aneurysmal segments diameters for choosing the right balloon. We consider the normal venous segments diameter for choosing the right balloon. Our preferable choice will be the non-compliant balloon followed by high pressure balloon. If the lesion is very much resistant, then we use the scoring balloon or cutting balloon followed by the high pressure balloons. So this is the balloon dilatation shown by here. We usually prefer the balloon dilatation under the fluoroscopy. When it is required to get the precise location of the lesion and do the balloon dilatation, we take the help of the ultrasound also. But ultrasound has the more role when we are planning to do the balloon dilatation across the anastomosis to just get the precise balloon dilatation across the anastomosis without occluding the complete brachial artery. This is the final check angiogram where you can see the brisk flow into the fistula vein with no flow into the proximal brachial artery. And along with that, return of the thrill. These three are our technical success parameters. We haven't used any lytic agents or mechanical thrombectomy devices, as these might be a costlier for our Indian scenario patients. In post-procedure, we usually keep these patients on Fragmin 100 units per kg once a day. Depending upon the thrombus load, we change the dose from 1 week to 1 week to 2 weeks, and single antiplatelet. We keep the patients on follow for screening for after 1 week, and followed by 1 month, 3 months, 6 months, and 1 year. During the follow-up, we access the puncture site for any puncture site complication. We see the culprit lesion for recall of the lesion, thrombus resolution, and check the flow in the fistula. So these are the follow-up screening scans where you can see the post-procedure. There is a lot of thrombus load is there, and subsequently there is a resolution of the thrombus can be seen. So we have done the 13 patients with similar, including BVT and BCAFs, where we have achieved a 92% of the technical success rate with 11 days time to resume the dialysis after the procedure, and primary patency at the end of 12 months is 84%. Complication, we have 2 patients with pseudoaneurysm at the puncture site, which were managed by the ultrasound guided compression, and we haven't found any thrombus migration into the brachial artery or no incidence of any pulmonary embolism. Advantage is that there is no need of any thrombolytic agents or thrombectomy devices. This is a daycare procedure. You can discharge the patient on the same day, and because of these two this procedure will be a very cost effective for the patients, particularly in India scenario. Limitation is that there is an increase time in the recannulation of the access after the procedure, and there will be a need of temporary dialysis catheterization for the patients to get them optimized and then do the salvage procedure. To conclude, plain balloon angioplasty without any adjunct thrombolytic agents or thrombectomy devices, which are costlier for our scenario, is safe, cost-effective technique to salvage the thromboaneurysmal arm accesses with good success rate and minimal complications and acceptable access salvage. Thank you, sir.
Thank you. Thank you, Dr. Manoj. We'll open the floor to questions from the judges.
Yes, sir.
Dr. Hambadi,
Yeah.
may I ask, in this patient, because he also have rather aneurysmal fistula of the largest part is about 1.8 centimeter. Would you consider using a small incision over the aneurysmal area to retrieve as much as the thrombus out before the balloon angioplasty, so as to quickly reduce the thrombus load? and the patient might be able to immediately use the fistula after your balloon angioplasty.
Yeah, ma'am, that can be done, but to be more non-invasive technique, and as I'll mention in the limitations, we get the patient optimized by putting the temporary catheterization. We first optimize the patients and get the procedure done. This technique also we have tried in 3 patients, but in 2 patients we got succeeded and 1 patient we haven't. But as we are getting more success rate in these cases, we are doing the same procedure in the AV grafts as well. So our primary patency rate is above 80% in all the cases. So we are pretty much happy with our technique. And one more, ma'am, as the patient, when we do the invasive procedure, the admission rate might be more. Here in Indian scenario, the patient will mostly prefer the cost-effective procedures, and they will prefer the less invasive procedures with more cost-effective. So it can be done, but this procedure is working for us quite well.
Okay, thank you.
Thank you, ma'am.
Hi, Tom and Joe. Thank you. Just a follow-up question. So what is the size limit of the aneurysm that you consider to use some more agents, or even say like what Professor Jackie just mentioned, to open a small incision to express out the thrombus?
I couldn't get you, sir. Can you repeat the question?
So how large the aneurysm, which you think just simple balloon maceration will not be effective and you choose other methods?
If I'm getting right, why balloon maceration is preferred than the incision. So as I mentioned, the balloon maceration, usually after doing the balloon maceration, there is one study I quoted in the presentation, where when the surface area of the clot get increased, the body's own thrombolytic agents will act, and the resolution will start naturally by the body. And as we are getting more resolution of the thrombus in the follow-up period, so there might not be need of any invasive procedure. Considering thrombolytic agents and operative procedure in India, it will be like 10 times what 10 times in the cost scenario than what we are doing now. If we use the thrombolytic agents also, it will be a 50 times more costlier than the temporary catheter what we are putting as the extra, as a limitation I have mentioned. And even if we do the thrombectomy, like mechanical thrombectomy, it might be around 200 and 250 times costlier than the simple catheterization what we are doing, and also costlier than our procedure also.
Thank you, Dr. Manoj.
Yes, sir. Thank you, sir.
To the judges scoring. One more participant.
Thank you, sir.
Thank you, Dr. Manoj.
Sir, can I share my slide?
Not yet, but just give us a moment. Okay, we would like to introduce the last contestant, and I'd like to congratulate everyone for making it so far. We are also quite just about on time. So we have Dr. Akshay Kumar Verma from India. Can you project your slides, please?
Good evening, everyone. I'm Dr. Akshay Kumar Verma. I'm a final year MCH trainee in Cardiovascular Thoracic Surgery Department, Grand Government Medical College, Mumbai, India. So my topic is Bridging the Gap, Prosthetic AV Fistula Graft, the last hope in dialysis-dependent CKD patient, a case series. So of all the trials a CKD heart may bear, none grieves like veins that vanish into air. When fistulas fail and hope runs thin, dialysis waits but cannot begin. So for me, the worst complication for a CKD patient on maintenance hemodialysis is not to have a suitable vascular access. However, in many patients, particularly those with unsuitable native vessel like sclerotic vein due to comorbidities such as diabetes mellitus, obesity, or multiple prior failed fistula, there is no suitable vascular access. In such cases, prosthetic graft become an essential alternative for establishing hemodialysis access. Autogenous AV fistula preferred due to better patency and fewer complications. However, advance in surgical technique and post-operative care and prosthetic graft have significantly improved graft outcome. Furthermore, in patients with unsuitable vessel, prosthetic AV graft are not only better alternatives, but they are the only alternative. So why should we consider prosthetic AV graft? We can consider it in patients with multiple failed fistulas or sclerotic veins, and it has a faster maturation rate as compared to the native AV fistula creations. There are multiple number of configurations through which we can use prosthetic AV graft like loop and straight, whereas it is restricted in case of native AV fistula because due to restriction in the anatomy. New innovations like heparin bonded graft and double layer graft has come into the market. Most prosthetic graft have an additional property of being double layered, which act as a low bleed barrier for cannulation needle holes and prevents hematoma and pseudoaneurysm formation and allows it to be flexible at curves without kinking. So we have done a study over 6 cases, and follow-up was taken for 24 months. Focus was done on patient selection, surgical technique, complication, and outcomes. Today are 6 cases. On the left, you could see the anastomosis that has been done for brachial. This is the tabular details of all the patients aging from 38 to 72 years old. Maximum patient for out of 6 patients, 5 patients had brachial loop graft and 1 had a brachiobasilic loop graft. We used tapered cortex EPTFE batch with 4 mm diameter on one side and 7 mm diameter on another side. Out of 6, the first patient had a complication of post-operative arm swelling post-operative on day 1, which was resolved by keeping limb elevated. The second patient had a venous anastomotic stenosis, which was treated with angioplasty. And the third one had an early thrombosis, which was relieved by thrombectomy. The fourth, fifth, and sixth patient had no complications. So patient selection was critical. Duplex ultrasonography preoperative was used for all the patients. Loop graft is offered better cannulation and patency. Early thrombosis, infection, and stenosis are main complications. Heparin bonded graft reduced early thrombosis. Preoperative vascular mapping was used for all the patients with multiple comorbidities such as diabetes mellitus, obesity, PVD, and prior failed access, known to predict poor outcomes with both fistula and graft. Studies have demonstrated that diabetic patients are not, and those with cardiovascular disease are at higher risk of prosthetic graft failure due to endothelial dysfunction and a higher propensity for thrombosis. Now, what are the choice of graft configuration? Technically, we have used all the loop configuration because it provides a greater granulation surface area, facilitates better dialysis, and offer more flexibility for puncture site, which increase the prolonged graft life. In contrast, straight graft are technically simpler to implant, but may limit cannulation option and predispose to localized stenosis. Surgical technique. Attention to be given on the surgical technique, particularly at the arterial and venous anastomosis, because a critical role is being played in minimizing turbulence, intimal hyperplasia, and subsequent stenosis. The use of mediculous anastomosis suturing with minimal vessel manipulation and intraoperative assessment of flow are associated with improved early patency. Prosthetic graft also require careful tunneling through the healthy non-infective subcutaneous tissue, as tunneling through areas of previous infection or poor skin integrity increases post-operative infection risk. The complication, thrombosis and infection are the most common complication. According to literature, thrombosis is found in 20 to 40% within the first year, and infection is found in 10 to 20%. Peripheral vein stenosis is the primary cause of fistula and graft thrombosis. The formation of stenosis is initiated by endothelial cell injury, which leads to smooth muscle proliferation and neointimal hyperplasia. The most common site for stenosis in graft occurs at the graft vein anastomosis is in 80 to 85% of the time, which is similar to our study, followed by intragraft stenosis 11 to 15%, and followed by graft artery anastomosis 2 to 5% of the time. So what are the advances and the innovations? Innovations such as heparin bonded ePTFE graft aim to reduce thrombosis by decreasing platelet adhesion and fibrin formation. Propatein heparin PTFE graft offers significantly better long-term patency over the standard ePTFE graft, suggesting it may be used as a better alternative to a standard ePTFE graft for AV fistula creation. These technologies remain under investigation and not yet widely available for clinical use. If the upper extremities are exhausted, we can go for a lower extremity graft also, and the outcome is equally well. But in our study, we have not used lower extremities. Compared to native AV fistula, prosthetic graft have a lower primary patency rate, and aggressive endovascular intervention, advancement in graft material, and structured surveillance programs can improve the durability of prosthetic access. So conclusion, prosthetic AV graft remain a life-saving option when AV fistulas are not feasible. Careful patient selection and surveillance improve outcome. Innovation may address the current limitations. So when veins can't connect the dots, graft bridge the gap, keeping dialysis on track. Thank you.
Thank you. Any questions from the judges?
Dr. Verma, I just want to know from you. So, how many different types of prosthetic graft for dialysis access are available in your country, and how do you choose between the different grafts?
Ma'am, we generally use heparin extended PTFE graft. The reason is that it's a double layered graft, first of all. Secondly, it has a heparin bonded. So heparin bonded releases into the systemic circulations and it decreases the thrombosis chances and decreases the platelet adhesion. Secondly, the advantage of having a double layered graft is that if there is any leak, if there is any bleeding, it gets sealed by its own. So we have generally restricted ourselves to only heparin extended PTFE graft over here.
I see. How about the infective incidence of the AVG? Is there any data from your side?
Ma'am, in my study, there is no infection, but according to literature, there is 10 to 20% of infection. And another reason why I have not used lower extremities for graft, I feel personally that getting a graft in the femoral region would be more prone towards the infection process because that also depends on the patient's hygiene. That's why we have restricted our grafts to upper extremities only.
Okay, thank you.
Thank you, ma'am.
Can I ask what is your post-op antiplatelet regime?
So we have kept the patient on heparin for just one day at 100 IU per kg QID. And after that, we have shifted the patient on tablet aspirin 75 mg OD for 3 months.
Okay. Are there any other adjuncts that you give to maintain the patency for the AV graft?
So we asked him to go for a this one physiotherapy. We used to say smiley ball exercise in our setup. We used to give a smiley ball and ask him to pump as much as they can. They are able to do it.
Thank you. Just a comment that I like the poem at the start. Did you write it yourself for the second?
Yes, sir. Yes, sir. Thanks a lot,
It's nice.
sir.
Thank you.
Means a lot to me.
One last question from any judge. If not, I think the silence is getting a bit awkward. So we will proceed to just finish off. I'd like to invite Prof. Jackie Ho to give her closing comments, and also any of the other judges to give whatever input they have from today. And I also like to firstly also congratulate everyone for stepping forward, and it has been also very eye-opening.
Yes, thank you, Meng. Maybe we'll start from our judges. Dr. Chen, any comments or words for the contestants?
First, I would like to congratulate all the contestants for submitting such challenging case. I think they all handled the case very diligently. And then I think many of case illustrated that we need to very good understanding of the underlying pathology, and then to decide which is the best option for the patients. I think it's really in. And then we also need to be innovative to see what option we can help the patient to preserve their dialysis options. So I think this competition is really good for all of us to learn from each others, and then to stimulate our thinking to see how we can be more innovative and to progress in the future.
Thank you, Dr. Chen. Dr. Karunan?
Yeah, for me, specifically, congratulate to all the participants, to all the contestants for their very it's very challenging case. Yeah, and this competition is very good. Yeah, maybe that's all from me. Thank you.
Thank you very much. Professor Fu?
First, thanks for the invitations from you. And second is thank you for every competition. It's very many interesting cases showing here. And I'm really looking forward to meet some of you by the end of this month in Singapore.
Yeah. Thank you very much. And really, indeed, thank you every contestants to step forward to this competition. I have to say, these cases are really very challenging, and I really learned a lot from all of you. I think it's really a interesting as well as a learning experience. And I also want to extend my great thanks to all the judges, because you give out times and also a passion to this competition. And I have to say, in particular, Dr. Chen, he's now in Los Angeles. So now it's actually early morning. He's staying up from 3 a.m. to 6 a.m. now. Yeah. So thank you very much, and have a good evening, and we'll see each other very soon over the end of August. Take care. See you. Thank you very much. And by the way, we will quickly consolidate the scores, and our organizers, Luke and also Samantha, will work on the scores very quickly. And tonight they will send out the email to let all of you know. Again, I have to say, maybe not all of you will be able to make it to the final presentation on 29, but your cases are great. And thank you very much for all. And the information will be sent to you via email within tonight or tomorrow morning. Thank you very much. Thank you. Bye-bye.
Bye. Good night.
Good night. Good night. Have a good rest. Dr. Chen. Thank you.
Thank you, doctors.